Yeah, I invite Dr. Miraj to give his presentation. First, we can start now. Yes, start.
મોટા માથાઓ છે. આવ્યું? Done? Good afternoon, everyone. I am Dr. Miraj Chawda, second year resident doctor from BJ Medical College, Ahmedabad. Today I will present the case report of a dose of confusion, installation of omega-3 capsule in the eye. The aim of the study to report the misuse of an omega-3 capsule as an eye drops, emphasize the risk of using non-sterile product in the eye, highlight the importance of labeling, education and caregiver involvement. Material methods. Omega-3 are used for systemic inflammation and dry eye management. They stabilize the tear film, reduce the ocular surface inflammation and improve the meibomian gland function. Clinical assessment include visual acuity testing, slit lamp biomicroscopy, intraocular pressure measurement with the Goldman applanation tonometry. Now a 66-year-old male patient with the history of the both eye cataract surgery 7 years ago, right eye AG surgery 3 years ago, and history of diabetes mellitus since 3 years. He is the presenting complaint of the ocular surface discomfort, presented with blurred vision and redness in his right eye. History level is the self-treatment with supplementation. He believed to be the eye drops. The capsule was an oral omega-3 fatty acid supplementation punctured with the unsterile sewing needle and instilled directly into the eye. After the installation of the omega-3 capsule into the eye, his visual acuity decreased from counting finger 1.5 meter to hand movement with positive light perception and accurate projection of the ray. He has the severe conjunctival hyperemia, inflammation and corneal epithelial disruption, and sign of complicated pseudophakia, shallow anterior chamber and IOP significantly elevated. No sign of secondary glaucoma. His right eye visual acuity 6/9. He has mild conjunctival congestion and no sign of the intraocular damage. Investigation confirmed to no retinal or posterior segment pathology. Patient was started on intensive topical therapy. He started on carboxymethyl cellulose 0.5% as a lubricant every 2 hourly, cyclosporin, anti-inflammatories twice a daily, anti-glaucoma drug timolol, brimonidine, brinzolamide for IOP control, oral doxycycline 100 mg BD for anti-inflammatory support, and Osmega 500 orally resume after the clarification and education. Within 40 days, ocular surface inflammation reduced significantly and IOP normalized with medication, and patient's visual acuity in the right eye improved to counting finger at 2 meter. Discussion. Elderly patients are particularly vulnerable due to reduced vision, medical load, and lack of understanding of pharmacological distinction. Omega-3 fatty acid, though anti-inflammatory, are formulated for only systemic use. They are not sterile nor safe for direct ocular application. The lipid content may disrupt the tear film osmolarity and also change the ocular surface pH and contribute to epithelial toxicity and pressure changes. Healthcare provider must emphasize the medication review and verification of understanding at every patient interaction. Caregivers should also be included in such education to reduce the error. Packaging, differentiation, patient leaflets, and visual label can play an important role. The conclusion of this case report, this case highlights a preventable cause of ocular injury due to confusion between systemic and topical formulation. Detailed patient education, clear labeling, and vigilant follow-up are critical in the minimize such adverse outcome, particularly in population with impaired vision and cognitive limitations. Thank you.
Any question? I request Dr. Miraj to collect his certificate from Dr. Arvind More, sir. And now next speaker, Dr. Dista.
laser intervention in this patient to preserving the visual function and controlling the intraocular pressure. Material and method. This is a descriptive case study of the 56-year-old male patient who presented with a sudden painful diminution of vision in the right eye since 4 days, and the patient has had a history of right eye phacoemulsification surgery 4 months ago in the right eye. On the detailed clinical evaluation, the best corrected vision in the right eye was the county finger near face, and in the left eye it is a 612 with a hypermetropy correction. And right eye IOP was raised, and on slit lamp examination there was the circumciliary congestion and with the AC shallow and iris Bombay formation in this patient. And we on the ultrasound biomicroscopy there was the iris lens diaphragm with iris Bombay formation, and there is an anterior displacement of the iris lens diaphragm, and we also done the B-scan ultrasound which was normal. We started on the topical steroids in this patient, topical steroid, atropine ointment and brimnodine and brinzolamide to control the pressure. After 3-day follow-up, the medical therapy patient showed a symptomatic improvement within 3 days and vision improvement to the 6/36 vision, but IOP was remained 38 millimeter mercury, and slit lamp examination also with the retracted iris membrane with persistent iris Bombay, and we had undergone with in this patient ND-YAG laser in the right eye. And at 2-week follow-up, the then patient correction was improved, and it was a 6/18, and IOP was controlled at 18 millimeter of mercury in the right eye and 60 millimeter of the mercury in the left eye. We also examined the fellow eye to rule out any angle closure or malignant glaucoma type. So then we have done the in other eye the gonioscopy also, and it was found that the AC was shallow, and we had also done the PI in the fellow eye. Discussions. Malignant glaucoma, also known as the aqueous misdirection syndrome, it is a rare but potentially vision-threatening post-operative complication with anterior characteristic with the anterior displacement of the lens iris diaphragm, resulting in the shallow anterior chamber and elevated IOP. It is more common in the short axial lens, shallow anterior chamber, and in the hypermetropia patients. In this case, the patient also has a history of hypermetropia and undergone uneventful phacoemulsification, yet also presented with the malignant glaucoma including iris Bombay, shallow AC, and raised IOP. In this case, UBM also plays a very important role to rule out the other causes, and B-scan USG. We had done the medical management, which patient, as you see, patient was improved in this case. And laser intervention also provided the decrease in intraocular pressure over the 2-week period. This case also, we also examined the fellow eye, as I told, in which the angles were shallow, and we also done the PI to reduce the future risk of the developing the malignant glaucoma or angle closure disease in the fellow eye. Conclusion. Malignant glaucoma is very rare, but serious complication can occur after uneventful cataract surgery, especially in the eyes with hypermetropia and narrow angles. In this, the early clinical diagnosis and the investigative with the investigative approach, it is very helpful, and initial medical management and symptomatic relief can prevent the vision loss in this patient. Thank you. Here are the references of my case.
Thank you, Dr. Hargurpreet. I request you to collect your certificate from Dr. Jagdish Rana, sir. And now Dr. Vishnu Patel. And after that, next paper presentation, Dr. Sonali. Okay. Please be ready. Dr. Priyan, now we can start.
Hello. Hello everyone. Myself Dr. Priyan. I am presenting a case of necrotizing scleritis post-buccal surgery. The aim of this study is to highlight the clinical presentation, diagnostic challenges, and management strategies of surgical-induced necrotic sclerosis as a rare case but vision-threatening complication following scleral buccal surgery, and emphasize the importance of the early recognition and prompt the treatment to prevent the ocular morbidity. Material and method. A 64-year-old female patient presented with a complaint of severe pain, redness, discharge, and watering in the right eye 1 year post-scleral buccal surgery for the high bullous retinal detachment. Slit lamp examination was revealed the right eye lateral 20 by 8 mm area of the sclera melt adjacent to exposed scleral buccal. 6 mm lateral to limbus with the loose buccal suture was seen. The cornea is clear with the cataractous lens. Scleral scraping for the affected area was sent to the for rule out the infection, which turned out to be negative, and loose suture and scleral buccal were removed and sent for the culture, which turned out to be positive culture for methicillin sensitive staph aureus. Ultrasonography for left eye revealed a normal posterior segment. Systemic and autoimmune disease were ruled out by systemic investigation. Patient was started on topical antibiotic like ampicillin and vancomycin. Lubricant and oral and topical corticosteroid was given. After a 5 week of medical management, complete conjunctivization of the area of the sclera melt was seen. Discussion. Surgically induced necrotic scleritis is a rare but severe complication after ocular surgery like scleral buccal placement. Though mainly immune mediated, it can be triggered by the post-operative infection, especially when the buccal exposed or contamination occur. Infection may directly damage the sclera tissue or active immune response, leading to a scleral ischemia and necrosis. The scleral buccal act as a foreign body, worsening inflammation and tissue breakdown. Early signs include severe pain, redness, exposed buccal with scleral melting. Prompt diagnosis is essential to prevent the vision loss. This most often occur after multiple ocular surgery and is believed to be type 4 hypersensitivity reaction. In recurrent case, multi-layer amniotic membrane grafting with fibrin glue or scleral grafting can be tried. Conclusion. Surgically induced necrotic scleritis is a severe condition that can compromise the ocular and visual integrity. Proper diagnosis as well as early treatment is required to achieve remission, prevent relapses, and avoid structural complications. Since after buccal surgery, though rare, can present dramatically due to secondary infection. A high index of suspicion, prompt surgical intervention, and microbiology guided therapy are key to globe prevention. Thank you.
Dr. Priyant, please collect your certificate from Dr. Jagdish Rana. And Dr. Sonali, you can now start your paper.
Good afternoon, everyone. My topic is from
After
dislocation to vision restoration, a case of bilateral anterior lens dislocation treated with lensectomy and iris claw IOL. Our aim to report a rare case of bilateral anterior lens dislocation in young patient with homocystinuria and describe the diagnostic, surgical, and visual rehabilitation approach. Ectopia lentis can occur due to trauma or some certain systemic disease, including homocystinuria, Marfan syndrome. Homocystinuria is autosomal recessive metabolic disease caused by absence of cysteine beta synthase, associated with osteoporosis, thrombotic events, and mental disorder. Ocular abnormalities of this disorder are ectopia lentis, cataract, high myopia, iridodonesis, and retinal detachment. Lens dislocation is usually bilateral and inferonasal, so in our patient it was bilateral superotemporal lens dislocation. A 17-year-old male patient presented with gradually diminution of vision since childhood. Examination showed superotemporal lens subluxation of both eyes. Best corrected visual acuity was 660 in right eye and 618 in left, both with -8 spherical diopter correction. IOP was 22 mm mercury in both eyes, and fundus was normal in both eyes. Systemic blood investigation were normal except elevated serum homocysteine levels. The left eye underwent lensectomy with vitrectomy and iris claw IOL implantation. Vision improved to 612, partial with correction in left eye postoperatively. After 2 years, right eye presented with acute corneal edema, anterior chamber shallowing, and lens in anterior chamber with pupillary block. Vision was counting finger 0.5 meter in right eye and 618 in left eye with glasses. IOP was 40 mm mercury in right eye and 18 in left eye. Medical therapy included injection mannitol, oral glycerol, acetazolamide, and topical anti-glaucoma drugs were given. Right eye underwent lensectomy. Postoperative vision improved to 624 with phakic correction. IOP was 12 in right eye. Secondary IOL implantation was performed in right eye. Postoperative topical and systemic antibiotic anti-inflammatory IOP lowering agents steroid were given. Postoperative pseudophakic correction was 618 partial in right eye, 66 in left eye. Results in both eye after surgery, vision was improved and IOP was under control. Homocystinuria is typically associated with inferonasal subluxation, but superotemporal dislocation can also occur. Elevated homocysteine causes zonal fiber weakness, increasing the risk of spontaneous dislocation. High IOP may result from lens in AC, blocking the trabecular meshwork, phakomorphic or pupillary glaucoma. No systemic signs, highlighting the importance of biochemical screening in unexplained lens subluxation. Timely diagnosis and surgical management play a critical role in preventing irreversible visual impairment in patients with systemic and metabolic disorder like homocystinuria. Early surgical intervention in one eye, delayed presentation in other emphasize the need for lifelong monitoring. Elevated homocysteine can cause isolated bilateral subluxation without systemic sign. Consider homocysteine screening in young patients with lens dislocation, even if classical features are absent. Early diagnosis and stage surgical management preserve visual function and prevent glaucoma. Here are the reference. Thank you.
Thank you, Dr. Sonali. Please collect your certificate from Dr. Arvind More, sir. And next paper presentation, Dr. Soumya Manju. After that, Dr. Jagdish Patel, be ready. So, Dr. Soumya, you can start now.
Good afternoon, everyone present over here. Today, I'm going to present a paper on disc damage likelihood scale and its correlation with visual field indices and its accuracy in diagnosis of glaucoma. It is a single center prospective and observational study. The disc damage likelihood scale is a strong adjunctive diagnostic tool that aids in the diagnosis of glaucoma. The aims of this study is the DDLS score has been mentioned in the literature but never been used in the general practice of glaucoma diagnosis and staging. Through this study, we try to understand better the usefulness of DDLS scale as a predictor of glaucoma, its accuracy and correlation with visual field indices. Materials and methods, a single center prospective observational study. 198 patients were taken, out of which 120 were males and 78 were females, who were a known case of open-angle glaucoma. OCT and Humphrey's visual field were recorded. Then the patients were graded as mild, moderate, severe, and glaucoma by mean standard deviation severity staging method. That was 6, 6 to 12, and greater than 12. Then the DDLS compared against the visual field indices its accuracy in staging these cases of glaucoma. The results were found that DDLS and the cup disc ratio had a very strong correlation. DDLS and mean deviation has a strong and positive correlation. DDLS and the visual field indices had a good but a negative correlation. DDLS and foveal sensitivity had a weak correlation. The patients were divided into mild, moderate, and severe according to the mean deviation. 116 patients were found having mild glaucoma, 46 as moderate, and severe were 36. Out of this, using the DDLS scale, 36 were graded as at risk, 64 as glaucomatous damage, and 16 as glaucoma disability. Moderate, similarly, 8 were at risk using the DDLS score, 28 as glaucomatous disability, and 10 as glaucomatous disability. Hence, the diagnostic accuracy was mild had a 68.9%, moderate has 82.6%, and severe at 100%. DDLS scale was first described by Spaeth in 2002. It gives the importance to the pre-existing neuronal tissue, that is the rim, rather than focusing on the area of the absent tissue, that is the cup. Compared to CDR, it is superior as compared to the disc to rim to disc ratio. In our study, 6.8% with mild disease, 82.6 with moderate disease, and 100 with severe disease were accurately diagnosed as glaucoma by the DDLS scale. DDLS has shown to be appreciably correlated with various visual field indices in our study. Hence, the DDLS appears to be a good method that can be used in glaucoma patients, but not proven in glaucoma practice. The 16 patients which were seen having foveal sensitivity as greater than 30 decibels and visual field indices as greater than 90% were wrongly categorized as having severe disability, which proves the point that DDLS does not correlate with the functional status of the patient. Our study has been a curiosity study that touches on the DDLS staging, which needs to have multiple studies to solidify the further investigation in its usefulness in basal clinical practice. Hence, the conclusion was DDLS is a strong predictor of disc damage as it utilizes rim to disc ratio for evaluating the disc damage. It correlates appreciably with visual field indices, but does not help to assess the functional status of the patient. As there is no single absolute test for diagnosis of glaucoma, it acts as a test for glaucoma diagnosis. Thank you. These are my references.
Nice presentation. Kindly collect the certificate from Dr. Ashish Saxena, sir. Next presentation from Dr. Dusty Patel. And please, Dr. Ditsa Parikh, prepare yourself.
Good evening. Today I am presenting a case, rare case of bilateral eye syndrome in young adult male patient. My aim to report a rare case of bilateral iridocorneal endothelial syndrome in 25-year-old male with emphasis on the importance of early diagnosis, intraocular pressure monitoring, and timely intervention to prevent glaucomatous damage to preserve visual function. This patient present to OPD with the chief complaint of diminution of vision since past 3 years. And patient is consulted outside, and patient is using brimonidine plus timolol eye drop twice a day. A detailed evaluation including a visual acuity slit lamp examination, ASOCT, specular UBM for anterior segment evaluation, and USG and fundus examination for a posterior segment evaluation has been done. Based corrected visual acuity of right eye is the plano CF 3 meter, and for the left eye plano 6/18. In the right eye, in slit lamp examination, lid lacrimal apparatus is normal. Corneal edema with peripheral corneal degeneration is present. Anterior chamber is almost flat. Iris irregular in size and shape, and adherence is either to cornea. Lens is clear, but in the left eye, lid lacrimal apparatus is normal. Corneal edema is present with peripheral corneal degeneration with iris pigmentation over the endothelium. Anterior chamber depth is shallow. Iris is irregular shape and size with iris atrophy is present and correctopia is present. Temporally, localized calcified cataract in this left eye. Intraocular pressure for the right eye is 20 and left eye is 22 millimeter of mercury. Fundus examination for right eye is 0.7 CDR with deep cup and foveal reflex present, and for the left eye 0.4 CDR and foveal reflex present. Ultrasound biomicroscopy of the right eye suggestive of iris adherent to cornea, corneal endothelium, and for the left eye suggestive iris adherent to cornea almost more than 270 degree. Specular biomicroscopy suggestive is abnormally large and round endothelial cell, decrease in number, displaying light dark reversal, peripheral dark area with peripheral light area with central dark. This called eye cells. Both eye ASOCT is seen in photograph. Right eye USG suggestive of posterior segment normal with deep cup, and for the left eye USG suggestive of posterior segment within normal limit. Treatment of this patient, currently we are using a medical treatment for the both eye. Sodium hyaluronate drops for surface lubrication, and netazoidal used for bedtime to control the raised IOP. Specific for the left eye, targeted anti-glaucoma therapy including dorzolamide, brimonidine, sodium chloride ointment to manage the corneal edema, and also patient is using tablet acetazolamide for systemic IOP control. And patient is advised regular 3 weeks follow-up. And if the pressure is not controlled, surgical intervention is targeted. IOP is not achieved with current therapy. Iridocorneal syndrome is a rare syndrome, and there is a 3 variant is present: progressive essential iris atrophy, Chandler syndrome, and Coronary syndrome. Conclusion is the diagnosis with bilateral ICS syndrome is a rare disease of idiopathic cause affecting the corneal endothelial and leading to secondary glaucoma. The condition has resulted in significantly raised IOP requiring topical and systemic therapy. Despite medical management, IOP control remains inadequate, especially in the left eye. The patient is advised regular 3 weeks follow-up IOP monitoring and consider for anti-glaucoma surgery if the poor response to medical treatment. Thank you.
Thank you. Please collect certificate from Dr. Bakules Kamar sir. Next presentation from Dr. Deepsa Parikh on optic dispute maculopathy.
Stop. Good afternoon, everyone. Today, my name is Dr. Deepsa Parikh, second year ophthalmology resident at BJMC, Ahmedabad. Today, I'll be presenting a case of optic disc maculopathy, a rare and vision-threatening anomaly. Optic disc pit is a rare congenital anomaly due to incomplete closure of the embryonic fissure. It occurs in 30 to 75 cases and causes fluid accumulation under or within the retina, can be subtle or often misdiagnosed, leading to irreversible central visual loss. PSOCT and EDI-OCT are essential for diagnosing, monitoring, and planning management. Aim is to highlight the clinical features and image-based diagnosis of optic disc pit maculopathy. If it left undiagnosed and untreated, it can result in irreversible central visual loss, especially in young patients. Early recognition prevents visual loss. So there was a 70-year-old male patient which came with painless progressive diminution of vision in left eye for 6 months, no history of any ocular trauma, spectacle use or previous eye disease, no significant systemic illness, positive for glaucoma history in a grandmother and aunt. Clinical features are visual acuity in right eye 6.6, left eye 6.12, anterior segment were normal and intraocular pressure were 14.14 in both the eyes. Fundus examination reveals clear right eye clear media, 0.5 CDR with lamellar dot sign and nasalization of vessels. Positive foveal reflex in left eye temporal optic disc pit with serous macular detachment. Here's the result. This is the fundus photography in right eye and left eye, EDI-OCT. EDI-OCT reveals clear visualization of optic disc pit, separation of inner and outer retinal layers, helps differentiate from morning glory disc and other optic nerve disc anomaly. PSOCT reveals retinoschisis with vitreous traction and subretinal fluid. Management includes conservative management, mild cases can be managed with observation, regular follow-up, including OCT monitoring for any progression. Surgical intervention include vitrectomy may be necessary for significant traction or macular damage, along with possible laser photocoagulation or macular hole surgery. Monitoring and regular follow-up with OCT and visual acuity checks is essential to assess the disease progression or complications. Optic disc pit maculopathy often mimics other optic nerve anomalies. Young patient may be asymptomatic or present with gradual visual loss. Multimodal imaging like OCT is vital for early detection. Differential is morning glory syndrome. Conclusion is optic disc pit maculopathy is rare but vision threatening. Early detection and timely referral are crucial. Always consider optic disc pit maculopathy in unexplained macular changes in young patients. Here's my references and key messages. Simple optic disc pit can cause significant visual morbidity. Maintain high suspicion for optic disc pit maculopathy in young patients with macular fluid. Thank you.
Thank you. Good case and nice presentation. Please collect your certificate from Dr. Jagdish Rana sir. Dr. Sandhya Kapadia, next presentation on orbital roside orphan syndrome.
Good afternoon. I am presenting a case on orbital roside orphan disease. My aim is to present a rare case of bilateral orbital roside orphan disease with submental lymph node involvement, emphasizing the diagnostic challenges and histopathological features and effective response to immunosuppressive therapy. A 57-year-old female presented with bilateral eyelid swelling and proptosis for 4 years. A similar episode occurred 6 years ago. For that, MS-CT scan was done, which revealed the diffuse enlargement of extraocular muscles and lacrimal glands. Histopathology examination suggested the inflammatory lesion, and neck ultrasound revealed the bilateral cervical lymphadenopathy, bulky submandibular glands, and hyperechoic thyroid lesion. On examination, the patient with visual acuity in right eye CF counting fingers 1.5 meters in right eye and in left eye 6 by 6. There is a firm non-tender mobile swelling involving both upper and lower eyelids in both eyes associated with erythema and mild ptosis of upper lids. Conjunctival congestion is noted 360 degrees. The anterior segment is within normal limits. The right eye is cataractous while the left eye is pseudophakic. Extraocular movements are mildly restricted in both elevation and depression in both eyes. Fundus examination findings are within normal limits. Bilateral submental lymph nodes are palpable on clinical examination. On CT scan, paranasal sinuses plus orbit suggestive of chronic inflammation of bilateral extraconal orbits with proptosis involving masticatory muscles and parotid and submandibular glands. Incisional biopsy from the right upper eyelid was sent for histopathology. On histopathology, examination shows mixed lymphocytes, plasma cells, and large histiocytes with vesicular nuclei and engulfed immune cells, characteristic of Rosai-Dorfman disease. There was a rapid improvement in clinical and physical symptoms with minimal side effects following the use of antimetabolites, tablet methotrexate for 15 milligram once a week and corticosteroid tablet prednisolone 40 milligram once daily, initiated after consultation with rheumatologist. On discussion, orbital Rosai-Dorfman disease is a very rare entity, particularly on older adults with bilateral involvement. In this case, the presence of chronic eyelid swelling, ptosis, and mild restriction of extraocular movement suggested a slowly progressive orbital process. Imaging revealed bilateral orbital involvement, but definitive diagnosis was achieved through histopathological examination, showing empyropelesis, a hallmark features of Rosai-Dorfman disease. Associated submental lymphadenopathy supported nodal involvement. The condition typically responds well to corticosteroid or immunosuppressive therapy such as methotrexate. This case highlights the importance of biopsy in evaluating chronic unexplained orbital swelling. Orbital Rosai-Dorfman disease is a rare benign histiocytic disorder with distinctive clinical and histopathological features. Diagnosis relies heavily on imaging and definitive histopathological features. Most cases respond well to corticosteroid, but severe or refractory cases may need immunosuppressive therapy or surgery. Early recognition and multidisciplinary management are crucial for preserving vision and preventing complications. These are my references. Thank you.
Thank you, Dr. Sandhya, for your presentation. I request Dr. Amit Patel sir to give her certificate. And I request all residents to come on dais for a group photograph who have presented their papers here. Sir, please.
इसमें डाल दें सर ये सर्टिफिकेट.
Next session will be Protect session. Please come. Yeah, come. Thank you. In next session, I invite Dr. T.P. Lane sir, Dr. Shashank Patel sir. Sorry, we are before time. So yeah. Sorry, sir. Then we will start on 2. Okay. Thank you. Bye-bye.
Mola Gandhi. My topic is Kahuk dual blade goniotomy. So, majority of aqueous humor flows via trabecular meshwork to Schlemm's canal, extending through the collector channels, then into the episcleral veins. So, aqueous humor, 70 to 80% aqueous humor drain via this pathway. In primary open-angle glaucoma, the trabecular meshwork acts as the greatest site for resistance of outflow. So, in POAG, the increased intraocular pressure occurs when TM is diseased and not functioning properly. So, there are glaucoma surgeries which are available for two types of glaucoma surgeries. One is conventional anti-glaucoma surgeries, in which we create the subconjunctival bleb pathway. The surgeries are trabeculectomy, Ahmed glaucoma wire surgery, Barrett valve surgery, and Ahmed clear path. The newer generation micro-incisional glaucoma surgeries or minimally invasive glaucoma surgeries which are available, which increase the conventional trabecular outflow or suprachoroidal outflow. The increasing trabecular outflow pathway, there are eye-stand device, hydrus device, GAT, KDB goniotomy, viscodilatation and bang, increase suprachoroidal outflow via CyPass shunt. So we will more discuss about KDB goniotomy. In past, the traditional goniotomies are preferred in congenital glaucoma in pediatrics patient, but that surgery is unable to lift trabecular meshwork. So residual leaflets of TM is present in the eye, but new excisional goniotomy are performed in pediatric and adult patients across the according to the severity of disease. It elevates and excises TM to assess multiple collector channels, and excisional procedure minimize the residual TM leaflets in the eye. So the new Kahook blade, which is designed in that way that the tip ramp and dual blades, the tip actually pierces the trabecular meshwork, the ramp lifts the trabecular meshwork and stretches the trabecular meshwork, and the ramp rests on the canal wall, and the dual blade remove or excise the trabecular meshwork from the eye. The benefits of excisional goniotomy with Kahook blade is it excises the strip of TM, so no remnants of TM present in the eye, so there is less chance of post-op scarring and post-op resurgery. It's an implant-free procedure, and it can be performed with cataract surgery also. So who are the good candidates for KDB goniotomy? All primary open-angle glaucomas, mild to moderate glaucoma, pigmentary and pseudo-exfoliation glaucoma, where actually the pathology lies in the trabecular meshwork itself, and all cases with clear cornea. So the view of gonioscopy is good. Relative contraindication for goniotomy are usually any angle closure glaucoma or cynical angle closure on gonioscopy, severe glaucomas, or any patients where the target IOP is less than 10 mm of Hg, active neovascular glaucoma, active uveitic glaucoma, or elevated episcleral venous pressure. What is the pre-op preparation for KDB goniotomy? Usually, if we are performing the surgery with cataract surgery, we use dilatation drop 3 times every 5 minutes, antibiotics 3 times every 5 minutes, and if we are doing a standalone procedure, use pilocarpine eye drop. In intraoperative, usually we use pilocarpine eye drop if we are doing the surgery with cataract surgery, and after putting the IOL, we usually perform KDB goniotomy. Every surgeon should perform pre-op direct gonioscopy, pre-op gonioscopy, so we can see the angle structures. Intraoperative gonioscopy, how we assess intraoperative gonioscopy. First, tilt the patient say 30 to 40 degree away from the surgeon, microscope 30 to 40 degree towards the surgeon, and doctor should sit temporal side of the patient, so nasal angle is easily visualized, and do as magnification as possible during the surgery, so angle structures are easily visible. Usually this type of angle structure should visualize during the surgery. The KDB goniotomy is usually performed via clear corneal incision, just like cataract surgery, but we should put the clear corneal incision just anterior to the limbus to avoid any bleeding, because bleeding can hamper the view of gonioscopy. After putting the direct gonioprism over the cornea, just add Hilon viscoelastic substance into anterior chamber and add the Kahook dual blade into the anterior chamber and remove the trabecular meshwork via 3 pathways, 3 techniques. One is inside to outside technique, second is outside to inside techniques, and third mark and mid technique. Usually KDB blade can use to do 120 to 180 degree nasal goniotomy. During the surgery, if blood was out, that's a good sign, and use Hilon viscoelastic substance to control the bleeding. Usually KDB blade is designed in that way that removes the TM within it, but if the remnants of TM are present in the eye, we should excise it with ILM forceps. And if we are performing the surgery with cataract surgery, first go for cataract surgery, put IOL, and then go for KDB goniotomy. What are the most common complications is hyphema. It is usually occur in all the patients, but it's self-resolving, and sometimes very rare cases it need ASHIVOS. Transient IOP spike, iridodialysis, corneal edema, or if IOP is not controlled with surgery, we have to go for traditional anti-glaucoma surgery. Post-op regimen is steroids, antibiotics, cycloplegic, usually 1 month, 4 times, 3 times taper off. But if the patient is steroid responder, go for soft steroids like FML or Lotipred. Usually, if post-op IOP is high, we can add any one of anti-glaucoma medication in post-operative period. So KDB is an effective MIGS surgery for early to moderate glaucoma, which do 120 to 180 degree goniotomy. KDB is a good alternative for the patients who has poor compliance and poor affordability to anti-glaucoma drugs. It reduced 20 to 30% IOP in long-term duration and can also perform with cataract surgery. I have a small surgical video of KDB surgery.
Yeah, please conclude. Just fast.
So this is direct gonio prism to visualize the anterior chamber structures. I enter the KDB blade into anterior chamber. I am using inside to outside technique in this surgery. So the KDB blade is removing the trabecular meshwork in the surgery. From inside to outside technique. The blood oozes out during the surgery. Some amount of trabecular meshwork is on the blade after adding Helon in the anterior chamber. The small strip of trabecular meshwork is seen in the AC, which was removed with the help of ILM forceps. So we all can see how beautifully KDB can remove the TM itself. This is trabecular meshwork, which we can see in the video. Same way I perform the other side of the surgery from inside to outside technique. So this way we can achieve 120 degree to 180 degree goniotomy. And it's just a 5-minute procedure.
Yeah. Okay, thank you, Dr. Amula. Please collect your certificate from Dr. Sandip Patel, sir. Next speaker will be Dr. Mihir Patel, who is talking on phaco in posterior polar cataract.
Hello.
So, Dr. Mihir, please start.
Hello. Good afternoon, everyone. I would like to thank a scientific committee of 4th Midterm AGOS conference to give me an opportunity to deliver a speech. I'll speak about the phaco in posterior polar cataract. It will be my approach how to deal in such a complicated case. First of all, anesthesia always should be an individual choice. My preference is peribulbar block. We'll go through various steps in the phaco, posterior polar cataract later on. In pre-operative management, I would like to say we should always be ready with the dispersive viscoelastic agent like Viscoat, standby 3-piece PMMA or the foldable IOL. Vitrectomy cutter should be in working condition. Pre-operative mannitol injection, always a surgeon's choice. And the consent for the second surgery, the most important thing. Moving forward with the steps. The first one, CCC. As you all know, we should always aim for a smaller size CCC. Like I aimed for the 4.5 to 5 millimeter size in both of my case. As you can see in the both surgery, the smaller size of the rhexis may help during the sulcus fixation of the IOL or maybe the optic capture in case of any PCR event. In the second step, the most important one is the hydrodelineation. As we all know, the hydrodissection in posterior polar cataract is contraindicated. So we must do hydrodelineation. The multi-level hydrodelineation is much better to separate a more segment. And if you see in the first case, I tried, but only two segment hydrodelineation done. But in the second one, I tried and it was around 3 to 4 segment. In the next one, phacoemulsification, we should always maintain the phacodynamics in such cases to avoid any intraoperative leaks. Low parameter phaco is advisable. Like I almost use low parameter phaco in all my cases, 24 flow rate, 250 vacuum, 40% of energy. As you can see, the superior part of the nucleus is very easily removed because of the hydrodelineation, but the posterior part and the peripheral part is not easily coming out. So we can use such type of spatula also to separate it from the peripheral part, but still I failed to do it. So I decided to came out from the eye after putting some viscoelastic agent to maintain the AC chamber. So it is most important to maintain the AC chamber in such cases. In the next step, cortical wash. The peeling of the cortical material from outside to inside is most important in such cases, leaving the central posterior polar component last. like this. When you are very much satisfied that all central posterior polar component is detached from the posterior pole, you can have the spatula and separated it like this. So from the total posterior capsule, and then the remaining part will be dealt with the irrigation aspiration port like this. And the cortical wash is done. In the next step, IOL insertion must be slow and very careful, because the leading haptic may touch the very thin posterior polar part of the posterior capsule and may lead to the damage, and it may cause the IOL drop also. So as you can see, in both cases, the slow and the gentle IOL insertion is done. After thorough visco wash, the wound closure in such cases must be very gentle. The hydro closure, as you can see, in the both side wood as well as in the main wood, should be hydrate very gently, very carefully. If you try to over tight the eyeball, it may lead to PCR even after the 100% successful surgery like this. Thank you. A letter, appreciation letter from the children of the patient makes you feel happy. Thank you so much.
Please collect your certificate. Would request Dr. Lane, sir.
Next speaker will be Dr. Nikhil Sathwara. He's not there. Then Dr. Ankit Patel.
Ankit Shah.
Ankit Shah. Dr. Ankit Shah for IELTS scrolling. And Dr. Utsav Padya and Dr. Khushbu is there. They are not here. Okay.
Good afternoon, everyone. I would like to thank All Gujarat Ophthalmological Society for giving me this opportunity. My today's topic is IOL scaffolding. I have no financial interest. What is IOL scaffolding? What is the technique? We will see the step-by-step overview, a key variation of that, risks, considerations, and conclusions. What is a scaffolding? It is an artificial temporary barrier. The concept is placing an IOL, usually a 3-piece IOL or any hydrophobic lens, to act as a temporary platform or scaffold inside the eye. The purpose is to create a physical barrier between the anterior and the posterior segments. The function, this scaffold provides a safe zone to handle the complications without risking further issues like lens fragments falling posteriorly. The scaffold IOL is the same lens that will be implanted in the lens, in the IOL. The indication, essential for the high-risk surgical scenarios, hypermature Morganglian cataract or small hard nucleus, there is loss of posterior capsular support. In cases of the PCR, the scaffold prevents the cataract fragments from falling into the vitreous, many a times preventing the drop and further fragments falling. In cases of the IOL exchange, when replacing the problematic IOL, the new lens is inserted as a scaffold, providing a platform to safely cut and remove the old lens, and in cases of the Somerin's ring removal. The procedure, we have to identify the complications, stabilize the eye, fill it with the visco, place a scaffold. The IOL is carefully inserted and positioned into the cover the capsule iris or the PCR by creating a platform. We have to manage the problem. We will do the phaco after placing the IOL and the final IOL positioning. In this case, as you can see, it is a hypermature Morganglian cataract. The capsular axis is being done. The cornea is a bit hazy. In cases of the hypermature cataract, we have to be very careful. The axis should not run into the periphery, and the nice and circular perfect capsular axis is being done. While I was doing the phaco by direct chop or multiple chop has been done. The 60% of the nucleus is already out, but the remaining 40% is there, and now the PC was coming up. So I thought, let me put the IOL inside. The leading haptic goes inside the bag, and the trailing haptic is above the iris, and which is safeguard for the posterior capsule. And now the remaining phaco emulsification is being done. So it becomes very easy for us to do the phaco for the last fragment, so we don't have the surge. And even if it happens, the surge, the posterior capsule will not get caught into the phaco probe, and the IOL will be there, so it will always stabilize the eye. The phaco emulsification becomes very fast in such scenarios. The haptic which is there inside, one haptic is there inside the bag. the phaco-emulsification becomes easy, the epinuclear material is out, and now we will just rotate the trailing haptic and put it inside the bag and the case is over. In this second case, this is a hypermature Morgangian cataract. As you can see, by just doing a nick, the white material is coming out inside the eye. They're relieving the pressure from the, I was just relieving the pressure from the inside the bag. And while I was doing that at the 12 o'clock, as you can see, the rhexis ran into the periphery. So I just completed the rhexis from the opposite end, and keeping in mind that at the 12 o'clock there is a rhexis ran into the periphery. I was doing phaco, almost 20-30% of the phaco was being done, and while I was removing this lens, the nucleus was just vertical inside the eye. So I carefully removed the probe, and I thought it is a better time to put a 3-piece IOL as a scaffold. So now the 3-piece IOL is there in the scaffold. The leading haptic is inside the sulcus. One second haptic was inside the anterior chamber above the iris. And in this manner, you can see that there is no vitreous inside. Vitreous does not come out. Fortunately, it was better for me so that I do not have to do the vitrectomy. The vitreous is not there, so the phaco fragmentation, it becomes very easy. The phaco is being done, and the 3-piece IOL is still there inside. And I just have to rotate it and put it in the sulcus because there is not enough capsular support, so we cannot put it in the bag. Now, this is another case. This is again a hypermature Morgangian cataract. You can see the white fluid, but I just completed, the nucleus is freely rotating inside the eye. I have just completed the capsular axis. It is a hypermature Morgangian cataract. The nucleus is very small and very slippery. So you can see that there is not enough hold to break the nucleus into 2 pieces. In spite of repeating attempts, it just slips away, and any jungle you can do, but the nucleus is separated. The piece is not being done. So I thought the nucleus is smaller in size. We can just fill up it with the visco, and we can just retract the nucleus inside the bag and insert the IOL inside the bag. So you can see the nucleus, whole nucleus inside the bag, and the lens is also inside the bag. Now, once the lens is inside the bag, it gives a posterior capsule a good support, and over which we can easily remove the nucleus, and it is just come out of the bag, and the nucleus emulsification and phaco-emulsification is very fast. And no worry about the posterior capsule. As you can see, the epinucleus is not there in case of hypermature cataract, and the lens is there in the bag, and case is over. So what are the advantages of IOL scaffolding? It enhances the safety, improves the outcome. It prevents a drop nucleus, prevents a major complication. It avoids larger incisions of doing SICS and ECC. It gives a greater surgical control. It can also be used in cases of the glued IOL or any other scleral fixated IOL when there is not enough capsular support. The risks and considerations. The corneal endothelial damage can be there because of the shallowing of the anterior chamber. You can use profuse viscoelastics. The IOL can also be damaged by the phaco, the scaffold IOL itself. There can be a raise in postoperative inflammation, a little bit of higher risk IOL malpositioning can be there. You have to be careful perfectly centering the IOL. You have to be cautious in cases of the complications, complicated cataract, uveitic cataract, and poor corneal endothelium. So by concluding, it is a best problem-solving tool whenever applicable. It enhances the safety. It transforms a high-risk situation into a controlled and manageable surgical environment. It improves the outcome by preventing severe complications. The technique leads to better visual outcome and faster recovery for patients. It empowers the surgeon. It gives the surgeon the confidence and the ability to handle unexpected challenges effectively and ensuring the best possible results. Thank you.
Thank you, Dr. Ankit Shah. Nice presentation. I request you to collect your certificate from Dr. T. Pilhane sir. Now I request Dr. Arvind More sir to give his talk.
So good afternoon, esteemed chairpersons and my dear friends. And a special thanks to the All Gujarat Ophthalmic Conference organizers, and especially Dr. Jagdish Rana sir and Dr. Parth Rana, Dr. Bhavik for giving me the opportunity. So I will be speaking on India's first bag-free ripacidil, that is Riposite. So it has advantages like reduced ocular surface disorders because it is BAK free, and there is improved patient tolerance and adherence, and less side effects like the reticular this epithelial side effects, and the potential for the improved tear film, and consideration for the glaucoma surgery or for the patient who are about to go glaucoma surgeries, and beneficial for the patients who are on multi-drug for the anti-glaucoma medications. And these not all preservatives are created equal. So this is Riposite. So it is a Rho kinase inhibitor, and it is used to treat glaucoma and ocular hypertension by lowering the intraocular pressure. How it acts? So because of the enhanced aqueous drainage from the eye, thus reducing the intraocular pressure. It is used as a last line or the tertiary line of treatment, typically prescribed when other therapies are ineffective and when the other therapies are contraindicated. So how it acts? So by inhibiting the ROCK1, the ripazodyl, there are 32 ROCK, these enzymes in our body. So it induces changes in the cytoskeleton of the trabecular meshwork cells and Schlemm canals endothelial cells. And these cytoskeletal changes leads to a reduction in the compaction of trabecular meshwork tissue, which in turn increases the aqueous outflow through the Schlemm's canal. And it also reduces the resistance to the aqueous outflow, further enhancing the aqueous drainage. Additionally, because it's a Rho kinase inhibitor, it has anti-inflammatory effects by inhibiting the immune cell infiltration and cytokine production within the trabecular meshwork, and also in the corneal endothelial cells, it has a protective and regenerative effect. As per, there are many studies, especially in the animal studies and one human studies. So these Rho kinase inhibitor, they inhibit the inhibitor. So these endothelial cells, they derive from the neural crest cells, and all these, the neuroectodermal cells and the neural crest cells, they lie dormant as a spore, which can be activated by using the Rho kinase inhibitor, just like the this Y27632. So it has indications. In the open-angle glaucoma as well as the ocular hypertensive patients, and the conditions characterized by the high intraocular pressure that can damage the optic nerve as a single or as an adjunct therapy. Now coming to the features of this ripazodyl, so it exerts a neuroprotective as well as the vasoprotective effects and relaxes the vascular smooth cells, induces vasodilations, and enhances ocular and retinal blood flow. So when we are treating patients who are about to go having a low BP, especially the patients who are marathon runner. So in these patients, we need this kind of a drug which has a vasoprotective effect. And also, as per some studies, it downregulates the vascular endothelial growth factor and decreases the foveal thickness in patients with diabetic macular edema. Also, it has anti-scarring agent, so because of the attenuation of the activation of conjunctival fibroblasts, so it reduces the bleb scarring in the glaucoma surgery, the filtration surgery. Now coming to the benefits. So it reduces up to 6.4 millimeter of Hg of intraocular pressure after 2 hours of first instillation, and up to 7.3 millimeter Hg of IOP after 2 hours of instillation. And there is safety and efficacy of long-term ripazodyl. There are a lot of studies of 0.4% instillation and higher baseline IOP, larger IOP reduction up to 37.5%. So there is significant IOP reduction in patients with pseudo-exfoliating secondary open-angle glaucoma, uveitis-associated glaucoma, and steroid-induced glaucoma. Thank you so very much.
Please collect your certificate, sir. Dr. Utsav is there or not in audience? Dr. Khushbu? No. Dr. Khushbu is not there. Okay. Dr. Nikhil Sathwara? Okay. Now, would like to invite Dr. Shail Vasavda, and he is speaking on optimizing the patient outcome with true EDOF-IOL.
Very good afternoon to everyone. We do receive research grant support from Alcon Laboratories. So, you know, when you look at such a patient in the OPD, black cataract, you're thinking of how am I going to chop? You're counseling them about a possibility of two-stage surgery, corneal edema, so on and so forth. And after all this discussion, the only question the patient asks is that all that is okay, but I hope after cataract surgery I won't be needing glasses. So that's the standard of cataract surgery that we have reached to, that irrespective of the type or complexity of cataract, everyone wants to be free from glasses. And with increased life expectancy, even in India, there is an increased period of active life. And with inflation, you know, nobody can afford to retire until they are fit and fine. And phones and screens, like we know, are taking all over, including from our vegetable vendor to everyone is having QR codes. So smartphones is something that is there irrespective of urban or rural lifestyle. So the most important way or easiest way you can find out what the patient is really looking for is to have, say, if you don't have time in your clinic, have your optometrist or your counselors fill up these questionnaires kind of a thing as to what activities they are more likely to be doing in their active life. And you can change the, IOL, tailor the IOL accordingly. But not all patients are suitable for the full range of IOLs, full range of vision IOLs like the trifocal IOLs. But still everyone wants to do everything without glasses. So for that, I think that's where the role of the extended depth of focus IOLs has sort of come up, with the major advantage being that here we are less worried about choosing the personality type and all the other issues about dysphotopsia, because most of these IOLs are free from dysphotopsias. The only negative is that they will need glasses for fine print reading, which I think most of the cataract population is quite used to. So if you tell them that if you stretch your phone away, increase the font size, increase the brightness, you may be able to manage. But if you want to hold your phone close by and read the WhatsApp messages without enlarging the font or brightness, you will need some form of reading aids, and there will be a marginal loss of contrast in dim light. So let's go through some cases. This was a senior manager in a factory, 30 kilometers away from Ahmedabad, and a myope since a young age, and now due to cataracts, he's developed glare while driving. So now he started to having to carpool with some of his juniors because he finds very uncomfortable in driving back home. Because when he drives back home, he drives back from close to Bavra, and from there are no dividers and street lights until he reaches the main highway, and he feels very uncomfortable due to that. So his activities include supervision of the field force, checking the daily logs, and drive back to the city through country roads with no street lights or dividers. He wishes, of course, like everyone, that he doesn't have to wear glasses, but he doesn't want to compromise on night vision. And since glare and driving were his primary concern, therefore a trifocal was not suggested to him, and we decided to go ahead with a bilateral EDOF IOL, a Vivity IOL in this case, targeting emetropia, because that was his primary concern of wanting to drive himself. We explained to him that he will need glasses for fine print reading, but it will be less compared to a monofocal IOL. Binocularly, he did quite well. He does read with extra light N6, but we know that in real life, this is not a true N6 which we can promise to the patient. And he does say that he's able to drive comfortably, he's able to read his phone and newspaper comfortably on the screen by taking it a little far away. And he uses a 1.5 2.5 diopter ad for selectively while cross-checking bills and accounts, which he is quite happy to do that. The major concern that we had initially was that when you make these modifications on the surface optic of the IOLs, do they cause any internal aberrations? And this is the eye trace of that same patient showing practically no internal aberrations being caused by the change in the surface optics that are being done on these extended depth of focus IOLs. A 64-year-old lady actively does stock market trading like most Gujaratis do, analyzing daily on her desktop. Very well-to-do, but husband is suffering from chronic ailments and is almost bedridden. So she does the driving, she is active on the computer, she runs the house. 2 children, but both stay abroad. So she had hypermetropia with presbyopia, but wanted no compromise in the quality of vision. We went ahead, did the first eye, had decent intermediate and near vision. And in a normal situation, I would have chosen a 22 diopter IOL for a second eye. Here we decided to let us step up and see if doing a slight mini monovision helps us. So I went ahead with a 22.5 diopter IOL. and her near vision improved significantly, and binocularly she was almost, comfortable without glasses across all distances. She does find difficulty in reading the expiry dates on medicines, which I think even the most strong emetropes would find difficulty in, and uses a 1.5 diopter reading glass for that. And this is something we published, a randomized trial comparing bilateral emetropia versus the emetropia in one eye and minus 0.5 diopter in the other eye. And we found that the reading aid needed was significantly less. However, even the mini monovision group will need reading glasses for very fine print reading, so do not promise no glasses. And this is a final case, 83-year-old female, 6 months stays in Canada with her son and therefore is housebound and is used to now doing iPad all the time. Because of her nuclear cataract, she's not using any glasses, and these are the most difficult patients to satisfy. Unfortunately, she had a significant dry macular degeneration on her OCT and clinically, and therefore not a good candidate for trifocal IOLs. So we explained to her about an extended depth of focus IOL, a VVT in this case, and we explained that she will need glasses for reading. But post-operatively, she's very happy that she's able to use her iPad very nicely without having to use glasses. And she does even all her WhatsApp and everything on the iPad. And this is our recent publication, came up last month in the JCRS, where we compared the outcomes in dry age-related macular degeneration, and we found that the contrast and other issues are not affected when you have an early dry macular degeneration with the extended depth of focus IOLs. So you can extend the scope of these extended depth IOLs to select comorbidities. And therefore, I think you can use at least one of the two advanced technology IOLs for most of your patients. Thank you so much for the patient listening.
Thank you, Shail. Actually, EDOF is forgiving lens.
नहीं sir, वैसे भी हो गया.
Any question for any speaker from the audience?
Yes. So yes, sir, you're correct that how often do patients with mini monovision don't need glasses for near work? The problem is that the extended depth of focus IOLs do not behave classically like a monofocal IOL when you do mini monovision, because the extended depth of focus IOLs have changes in the optic which are little forgiving for a little bit of refractive error. So what we have found is that in trying to stretch the mini monovision anything beyond minus 0.5, it's affecting the quality of distance vision and the dysphotopsia significantly. So my primary strategy is not to offer mini monovision, is to offer bilateral emetropia and tell them that for fine print reading you will need glasses. If after the first eye the patient feels that no, I'm very happy with distance, if there's a slight compromise in distance, I'll manage, but if I can get a slightly better reading, I go up to minus 0.5. But anything more than minus 0.5, I would not be very comfortable with extended depth of focus IOLs.
So even in patient who is very unhappy with trifocal IOL. Recently, I did one patient. She was very unhappy with trifocal IOL done elsewhere, and she was very eagerly insisting removal of explantation. But 6 or 8 months passed, and then I advised to do another eye surgery, and I did EDOF IOL in another eye. Now she is very happy, and she never says about the explantation of the trifocal IOL. So it is one more advantage of EDOF IOL nowadays.
Absolutely, sir. It's probably the most forgiving IOL so far, which we have had in so many years of our. Thank you.
Any question? So Shail, please collect your certificate from Dr. Lane, sir. And would like to invite all speakers on the stage to have group photo.
Now I invite Dr. Divyang Brahmbhatt sir, Dr. Narendra Singh Verma sir, Dr. Ragini Parekh madam, Dr. Bhavik Rawal, Dr. Darshan Bavishi sir, and Dr. Jignesh Gosai for the next session of biotech.
टाइम सर चालेल पण फटाफट नाही.
Good afternoon, friends. I invite Dr. Saloni Shah to come on the dais for the topic of refractive outcome and visual quality with phakic IOLs. Should you choose one for your patient? Dr. Saloni. Your talk time is 7 minutes.
So from the audience, can somebody please tell me who these are? Everybody's still sleeping post-lunch. So Joe Jonas, a musician. This is our very own Rakul Preet Singh, the Bollywood Indian actress. He's a national basketball player, NBA. And yes, a Cobra Kai. She's patentless, an actress and a model. So what is common amongst all of them? All of them have been implanted with phakic IOLs. Good afternoon to one and all present here. I'm Dr. Saloni Shah, consultant ophthalmologist with Spectra Eye Hospital, division of Dr. Sanjay Gandhi Eye Hospital, Ahmedabad. The topic for today is refractive outcomes and visual quality with phakic IOLs. Should you choose one for your patients? I have no financial disclosures. The scope of my talk shall include the following. Myopia has already affected 30% of the population in 2020 and is expected to increase by 50% by 2050. The increasing prevalence of myopia is an epidemic. The topic at hand is very relevant as there's a high demand for myopia correction. Phakic lenses are effective for correcting refractive errors and they provide a reversible alternative to LASIK. A brief overview, we have the anterior chamber angle supported lenses, the anterior chamber iris fixated, and the posterior chamber lenses. It was in 1950 that Strampelli first implanted the rigid IOL. Then it was in 1980s that we had a first posterior chamber IOL. In today's day and age, we have a single piece aspheric plate haptic, a posterior chamber phakic IOL. It has a central aqua port, also 2 holes for orientation, leading left and trailing right. Also, there's a forward vault to minimize or decrease the contact of the lens with our anterior capsule of the crystalline lens. Since the last 40 years, Star ICL has been a global leader, delivering the consistent and good performance. Recently, Acryl lens has also entered the market, and it is a new exciting kid on the block. These are the two differences, the main differences between both the lenses, the Acryl phakic and the EvoVision ICL. I felt it was very essential to conduct a comprehensive literature review before incorporating it into clinical practice. The key insights from the literature reveal that both the lenses have visual and refractive outcomes which are safe and predictable. With Acryl's 3 and 7 years durability shows a similar efficacy. The endothelial cell loss was 2.7 and 3.19% respectively. When it comes to toric astigmatism correction, a 2-year prospective study found both the lenses to be equivalent in efficacy and patient satisfaction. Acryl lens showed a dynamic vault stability, that is, a lower vault fluctuation under different mesopic, scotopic, and photopic conditions. This was published in the Journal of Cataract and Refractive Surgery, 23, and showed that acrylic phakic lenses is a safe and effective surgical method in correcting high myopia with predictable and stable refractive results over a 5-year period. Another study of a 2-year prospective comparativity study regarding the toric IOLs showed that both the lenses were safe and effective in managing high myopic astigmatism and had similar patient satisfaction. A comparative study presented at ESCRS 23, which had a 9-month follow-up, found significant less fluctuations when it came to dynamic vault changes in acryl lenses. It was statistically significant. The fewer fluctuations may reduce the long-term cataract risk in eyes with low vault. And the reason for the fluctuation was attributed to the material differences, ICL being collamer, that is a collagen polymer, and hydrophilic acrylic when it comes to phakic IOLs. With all these points in mind, I was keen to evaluate the real-world performance. In my practice, I have used both the lenses, the acryl phakic and the phakic toric. As we are aware, they are made from hydrophilic acrylic material. It provides a very wide range of power correction from +10 to -25 and a cylinder up to 5 diopters. It can be inserted through a very small incision, 2.2 millimeters, whereas we work with ICL, we are aware that it requires a 3.2 millimeter incision. The lens is customized according to the shape and size for each eye. The toric lenses come from 11 millimeters to 14 millimeters, and these are the readily acceptable models. This is the BHAGWATI calculator, and the key strength lies in its ability to correct a wide range of power and give us customizable results for high astigmatism. This patient had a pre-op astigmatism of 6.5, so it is very ideal for complex and refractive cases. Also, a predicted post-operative vault can be judged from the calculator, so we can assess the sizing accordingly. White to white is a very important and a very crucial parameter for ICL lens sizing, and this takes into consideration 5 machines and adjusts it accordingly. So when it comes to a toric IOL, for the phakic acryl, these are the various axes available for astigmatism correction. So we don't have to actually rotate the IOL. In cases when we have to rotate, it is only 15 degrees. The main reason for decreasing the rotation was the 4-point contact that is necessary for the stability. So when we rotate the lens clockwise or anti-clockwise, all the 4 haptics are in contact with the ciliary sulcus. When any rotation is more than that, for example, 22.5 degree, which is done in many cases, there is decrease or separation of the haptics from the ciliary sulcus. In my surgical experience, loading is the most important step when it comes to phakic IOL. So the new injector that they have introduced gives us a great surgical experience. It is compact, easy to load, and remarkably time efficient. Inclusion of the backup lenses also provides an extra layer of peace of mind, especially to the new surgeons or the high volume surgeons. This is a refra injector. Just take a minute. It comes in a pre-packed sterile bag. It has a 2 millimeter incision. It has a dual mode of insertion. It can be introduced via a push mechanism, a screw mechanism, or while opening the flanges, it can also be positioned by a push mechanism. Saline is put, and then we have a layer of viscoelastic. This is a most different step where you take the lens and just put it in a concave position. It is exactly similar like handling our IOLs. We just align the lens and then close the cartridge. And then we are done. You rotate the cartridge with bevel down, and the insertion is a very seamless procedure. I have no financial interest, but as an upcoming neurosurgeon, I feel it has been a very easy road for me personally. My insights, offering affordability, precision, and visual quality, the acrylic lenses has made the high-end phakic correction accessible to a broader patient base. It is a viable, evidence-backed alternative, a distinct advantage for surgeons initiating phakic IOL practice because of the simplicity and the user-friendliness of the injector system, making the transition to the phakic IOLs very easy. Also in complex cases, because of a wider customization range, we can opt for one. So these are my Joe Jonas and Rakul Preet Singh. Thank you everyone for your time.
Saloni, you said the range is from +10 to -25, right? Yeah. अरे इधर देखो यार उधर इधर किधर देखती है? You said the range is +10 to -25.
Yes.
Right? I had the patient -22 and -25. Right. But the ACD was not enough. Right. You said it's customized.
Right.
So how to proceed?
No, sir. We can only proceed with the lens if the pre-requirement or the prerequisite criteria are fulfilled. So the ACD is one of the most important parameters. So after the ACD check is done, then if it is still not coming within the range, then we can get it customized.
The customized for the ACD only, I said.
No, sir.
The ACD was not sufficient for customization also.
No, so the ACD is not sufficient. We cannot proceed with the phakic IOLs. So for that case, we have to choose an alternative surgical method.
What's that?
So customization mainly to include the wide dioptric range if the ACD is compatible.
What's the alternative refractive surgery?
So if it is suitable for the surgeon and the patient, a refractive lens exchange becomes the option.
You lose the accommodation.
Yes, sir. So only that if it is comfortable.
Saloni, very good presentation. I would like to ask you one question. What are the ranges of higher side of myopia we will take in your surgeries? Highest numbers of myopia for acryl phakic lenses?
Yes, sir. We've used acryl lenses till -12, -18.
-18.
Yes.
So would you adjust anything for a higher myopic side to keep a little under correction? Because most of the patients with higher myopia, if you implant and keep them 0, they generally complain of near vision loss.
Yes.
So would you be adjusted to somewhere around half or 1 diopter less?
Yes, sir. One of the most important things is I counsel my patients. Secondly, for my personal experience, is I keep a -0.5 diopter, a spherical equivalent, the correction.
That is according to age, or at whatever age you will prefer the same?
If it is the patient is above 35, maybe between 35 to 40, and the patient still wants to go ahead with the ICL or a phakic lens, I explain the pros and cons, and then I might even put a correction at -0.5, 0.75, depending upon the age of the patient as well.
And in the borderline AC, like after removal of the corneal thickness, if your thickness, anterior chamber depth is, say, about borderline 2.85 or 2.9, would you go for preoperative iridectomy in such cases or not?
No, so I operated cases with the aqueous depth from 2.85 to like less than 3, so 2.85, 2.9. I have not felt the need for doing optical iridectomy. The central hole plus the 2 extra holes which are already present make the aqueous flow quite dynamic and natural, and there is no increase in the IOP.
Thank you.
Nice presentation, Dr. Saloni. Good comparison. Just I want to ask one question. You said the incision size is 3.2. So if you are implanting a toric lens, 3.2 incision size will give SI up to 1 diopter. So in some cases. So how you are tackling that? So there is refractive surprise in your cases sometime?
So, sir, with ICL, we need an incision of 3.2. When it comes to the acrylic phakic lenses, the incision of 2.2 or 2.8 suffices. So even that, I don't need any corrective factor. In most cases of ICL, like star ICL where I've operated, over a period of time with healing, the 3.2 incision goes away. It does not stay.
Thank you. I will request Ragini Madam to hand over the certificate. I will invite Dr. Bhavik Zala for his presentation. Our trifocal is still holding the ground compared to the latest development.
Thank you, sir. First of all, very warm welcome to all. Okay. Hello. First of all, very warm welcome to all the delegates and faculties. And also thankful to the scientific committee and AGOS for giving me this opportunity to give my talk. So today I'll be talking about trifocals. Are trifocals still holding the grounds compared to the latest developments? Let's see. There is no financial disclosure for this. So we've come so far from very old generation IOLs. In 2025, we are going with the trifocals. In fact, trifocal plus EDOF are on their age, and many companies are coming with the trifocal plus lenses. So still, we are in evolving phase year by year. What was the need for a trifocal, and does it still stand tall? A clear intention of trifocal was to reduce the dependence on glasses for majority of the activities without compromising on the distance vision, and also improving the intermediate vision. So I'll be dividing my talk in 4 sections: spectacle independence, wide trifocal, preoperative workup, and OptiFlex trio in personal. So what are the patient's expectation nowadays from a cataract surgeon? As Dr. Sahil Vasavda sir said, that everyone is requiring a very good vision, and in spite of seeing the complexity of the cases, everyone wants a glass-free vision. So excellent vision at all distance, low or no visual disturbances, spectacle independence, and most important, it should be cost effective. બધું જોઈએ છીએ પણ પૈસા ઓછા હોવા જોઈએ. So what are the options? Basically, now we are having EDOF, trifocal, bifocals. In fact, trifocal plus lenses are also available. Comparison between bifocal, mostly multifocal, EDOF and trifocal. Mainly, I would like to focus on the near vision. So whichever the patient requiring a absolute good near vision, along with the intermediate vision, trifocal is the only choice. Most of the lenses, most of the patients are happy with the EDOF lenses, but particularly those patients who is requiring a particular sharp and good clear near vision, they will definitely a suitable candidate for the trifocals. Gone are the days when intermediate vision was considered secondary, because nowadays every second or third minute we are on our mobile, we want to chat, we want to see messages, we want to do all our daily routine activities, but not compromising the distant vision. So trifocal IOL technology had a clear advantage over bifocal IOLs in terms of intermediate visual acuity, and near vision is statistically better for trifocals compared to EDOF. So compared to EDOF and bifocal, definitely trifocal has a clear-cut more advantage. Irrespective of the profession, the actor, if you are a swimmer, or if you are a farmer, professional, artist, everyone requires a good, clear, as well as intermediate vision nowadays. So those category in previous days that we are saying that only the housewife and household activity, females are a very good candidate for bifocals and trifocals, but not now. Everyone wants a crystal clear vision for the near vision, so they all are a good candidate for trifocals. Understanding the multifocal technology. So as we know that spacing between the rings will give you control on the power, and height of that ring will give you control on the light energy split. In bifocal, there is approx 20% of a light loss because of spacing and the height in the bifocal lens manufacturing. In bifocal refractive design, 40% of the incident light does not deviate, and 40% deviate and create another focal point. In trifocal, combination of the two diffractive patterns. Sorry. Yeah. So the core of the trifocal design is based on the combination of two diffractive profiles, one intending to provide added versions for the near and the other one to provide added versions for the intermediate vision. In trifocal design, second order diffraction of intermediate add and will provide energy to the near vision. So light loss will be 12 to 15% compared to 20% in the bifocal design. These are the prerequisite points for any good surgery and a good outcome. I will just skip these slides because of accurate biometry. We all know optimize A constant. Aberrometry is very well taken. If you are looking for an angle alpha, it should not be more than 0.5 mm because it can create compromised vision for your patient. So in such patient, monofocal will be a good choice. Dry up workup. As per your routine cases, it is very, very important because the first surface going to be impacted by the light will be the cornea. So dry workup is very much important. In particularly, I would like to talk about OptiFlex Trio, my experiences. So these are my old data, distant vision after 1 week and distant vision after 1 month, along with near vision. Very interesting defocus power curve for this OptiFlex Trio IOL because defocus curves demonstrate a perfect tolerance for residual refractive error. In spite of doing all these prerequisites and we encounter slightly here or there hyperopic or myopic shift, but these patients are with this OptiFlex Trio are very well tolerated with this slight amount of refractive residual error. And patient satisfaction ratio is very high with these patients. So why did it happen? And comparing to the other trifocal, OptiFlex Trio has a BLIS technology, that is brilliant light sensing system, giving you 40% far, 30% intermediate, 30% near in the daily daylight situations. Comparing with other trifocals, the beauty is it is very less rings compared to other competitive lenses. It has only 12 rings and 4 mm of diffractive areas. In our clinical experience, OptiFlex Trio demonstrate a real spectacle independence. Very few patients experience mild glare handlers. Definitely we have to counsel each and every patient for the same, and is more forgiving in terms of post-operative refractive surprise. So we don't need to worry about final visual acuities when 0.5 hyperopic or myopic shift in the case. With latest developments and increasing demands of the patient, trifocals still have their ground and are relevant in modern times and are there to stay with some more advanced modification to the optics like OptiFlex Trio Plus. There is a combination of trifocal and need-off that will match up our patient's expectation. Thank you.
Bhavik, you missed the biometric slide, right? But how far you rely
Because of the
on
constraint of the time, sir.
how far you rely on a constant of different companies having different IOLs, right? Do you consider a constant?
Yeah, definitely.
trifocals?
There is a trifocal constant, company A constant as well as surgeons A constants. There is particular SIA we have to encounter for each and every
It's
patient.
not that routine we used to do 118.2 and all that. They have a different a constant for different
Companies.
trifocals.
Yes, definitely. It is.
So before implanting, you have to ask for that a constant to the company, I suppose.
Yes, definitely. You can share the data to a company. They will calculate for yourself and they will deliver the lens accordingly, sir. Thank you.
I request Ragini Madam to hand over the certificate to Bhavik.
I invite Dr. Bhavik Zala. Topic is EDOP, a clear replacement of monofocal, understanding the design philosophy of ICL-SUT. What makes it special? Dr. Bhavik.
Hello. Good afternoon, everyone. First of all, I would like to thank the whole AGOS team and the scientific committee to give me the opportunity to speak on the topic. So I'm going to speak about the EDOF lenses. Dr. Sahil has also shared his experience and knowledge. But EDOF, a clear replacement of monofocals, understanding the design philosophy of ICL-SUT, what makes it special. I have no any financial associated with the product or with the discussion. I am sharing just my experience. So, friends, whenever you are offering your patients with a monofocal vision, a single vision, you can always offer the patient somewhat more range of vision for his intermediate work with no more cost also. So, why EDOF? If you see the monofocal lenses, it has a single focusing point which gives you a single vision, mainly the distance point. While as Dr. Bhavik has said, the multifocal has 3 focusing points. Which will you give the distance, intermediate and near focusing point, and will give you the all 3 visions. So why EDOF? The understanding the light drop profile in the various lenses. Our natural lens with the distance, intermediate and near vision. These are the monofocal lenses. This is with the bifocal lens, the light distribution. This is with the trifocal lenses, and this is with the EDOF lenses. Now, when to choose EDOF? It is always, nowadays we have many options for the patient. Previously we had only one option for the cataract surgery, that was the monofocal lenses. We used to do the surgery, put the IOL and send the patient back to home. And we were giving glasses to the patient. But now we have many more options. So according to the patient's lifestyle, we can treat the patient, give minimum spectacle or spectacle-free life to the patient. So when we have to choose, when natural halos and glare-free vision we want. One is functional, intermediate and near vision. And third is when patient is ready to wear glasses for near about 1 or 1.5 diopter. So you can always counsel the patient about the near vision, the near reading glasses. So you have to ask the patient that you will get a more glass-free vision for more of your work, 90% work, but for the reading you may require glasses also. So what is the EDOF spectrum? The pure EDOF is spherical aberration based and a pinhole effect. The hybrid is a refractive EDOF and pseudo non-diffracting beam, that is PNDB based. These are some company EDOF lenses or advanced monofocal lenses available. I am going to discuss about more today will be my experience with the iCRIL CERT, that is the advanced monofocal lens. So what is the technology? It is the enhanced intermediate vision without compromising the far vision. So first and foremost, whatever you are giving in addition to the patient, it should not be compromise your distance vision, because distance vision is utmost for every person. If you are compromising your distance vision, your night vision, then patient is not going to be happy whatever you have given for the near or intermediate vision. The photic phenomena comparable to the monofocal segment. So what to expect? Intermediate vision up to 57 centimeter and extended range of vision, that is 1.75 diopter at the 0.2 logmer or better vision. So what is the design of this lens? There are 5 zones in this lens. The zone 1 and 3 are having the higher power to provide the distance to intermediate vision. Zone 2 and 5 having the nominal power to provide the distance vision. Segmental zone 4 contains the nominal higher power at the 60-degree intervals to balance the energy, that is photopic and scotopic light condition. And the outer zone optimizes the radius of curvature and asphericity in the refractive zone, provides the extended depth of focus. And the central zone, lens can tolerate the large angle alpha and kappa also. So unique zonular asymmetry power distribution optimize the refractive zone to provide extended depth of focus. Asymmetric power distribution to provide the less pupil independence. Photic phenomena similar to the monofocal lenses, so you will get a good distance vision and minimal glare and halos. So patient can able to drive in the night also. So this is a picture showing range of accommodation. The human eye having a range of accommodation of plus 2.23 diopter. The range of accommodation with the age accommodation reduces and lost its ability to around 50 to 55 age. And then it progressed to cataract. So what is the possible solution to replace the cataract lens and achieve the accommodation property of this eye? So intraocular lenses that can replace the cataract, achieve the partial accommodation property, and give you the good distance vision. So the range of accommodation for the monofocal IOL, there is a large gap of accommodation because it gives a single vision, single focus point. While in case of multifocal IOL, you get a 3 focusing point which will give you a distance, intermediate and near vision, but there will be a gap between the distance point, the intermediate point and the near point also. So how to achieve the natural vision, that is the continuous vision? Solution is the extended depth of focus or EDOF IOL or advanced monofocal IOL. The EDOF IOL is a new intraocular lens technology in the treatment of presbyopia. In contrast to, can I take 2 minutes? Okay. EDOF lenses creates a single elongated focus point rather than to several multiple focusing point like the multifocal lenses. So I will skip the slide, and you can see the comparison with the first picture is for the monofocal IOL, which give you a single vision, the multifocal which give you with the 3 focusing points, while with the refractive extended depth of focus lenses, that is EDOF lenses, will give you a range of vision. So there is a no drop of vision between the focusing points also. So right patient selection and matching their expectation can give you the good results also. Clinical effectiveness criteria of the EDOF IOL are they have good depth of focus, good distance corrected intermediate visual acuity, and base corrected distal visual acuity also. The possible solution for the EDOF IOL or advanced monofocal IOL from the biotech group of company, which is ICRIL CERT, that is the advanced monofocal IOL, which come with no extra cost or very much less extra cost as compared to the monofocal IOL. So with no any added expense, you can give a better vision to the patient also. It is a new advanced monofocal IOL with aspheric surface, spectacle independence for the intermediate vision, and extended range of vision that is more than 1.75 diopter at 0.2 log MR or better, photopic phenomena profile similar to the monofocal IOL, and first preloaded advanced monofocal IOL available in the market. It is the so it has a unique zonular asymmetry which I have discussed also. Optimized refractive zone provide the extended depth of focus of intermediate vision, asymmetry power distribution, and provides less pupillal dependency also. So I will skip some of the slides and so how it is advanced monofocal IOL. So with the slide you can see it gives a 2 diopter of depth of focus field in the optical breach area as compared to the monofocal IOL. And with the other companies, how it is different. So we can compare with this ICRIL CERT with the Enhance IOL, that is with the Johnson & Johnson. What biotech company claims that it has a wavefront technology and unique zonular design. It has depth of field on IOL plane that is more than 2.2 diopter, which gives you on the spectacle plane with 1.75 diopter, which give you a more nearer range of vision. Post-operative results are comparatively good. Patient has good distance and intermediate vision. So in conclusion, summary, continuous means ICRIL CERT gives freedom from the spectacle for intermediate vision in daily activity. Continuous vision from distance to intermediate, very fast neural adaptation, minimal glare and halos, excellent performance in all lighting condition, very low chromatic aberrations, asymmetric power distribution to provide the pupillal independence, and extended depth of focus with a photopic phenomena profile similar to the monofocal visual disturbance. In many of my cases with the bilateral implantation, I have gained mostly in 90% cases N8 vision and distance is 6.6 vision without compromising the distance vision and night vision also. This is a short video showing preloaded implantation of this ICRIL CERT IOL. It is already comes in preloaded pack, so you do not have to interfere with the holding the IOL and managing the IOL. Just you have to put the viscoelastic on the tip and on the back of the IOL. Just slightly push the IOL from behind, close the clip, and you can easily proceed for the IOL implantation just with the tip of finger only. So it goes with 2.2 mm incision also with the wound assisted. And you can see the lens is going very smoothly and directly taking its position inside the bag. So thank you for kind listening. Thank you so much. Any questions are invited. Thank you.
Jala,
Yeah.
wavefront technology in refractive surgery, examiners, it's understood. But in lenses, I didn't get it.
They have made a lenses like they are getting a 2 or 2.2 diopter of intermediate additional vision of accommodation. So patient get an intermediate vision and distance vision also without compromising the distance vision.
The same is offered by others also. You mentioned something like refractive. What is that?
Refractive, that is the older platform which was available. The newer generation are available on this platform. So you will get a good range of vision, not only the fixed point of vision only.
Wavefront optimization. It is optimized.
It is optimized, not the laser. It is not wavefront laser. What we are using in laser.
It is not treating the irregularity of the cornea, but it is a optimization. This is whatever the abrasions, what we expect post-operatively, that can be corrected with that. Now I request Dr. Ragini to give the certificate to Dr. Bhavik Zala. I invite Dr. T.P. Lahane, our national faculty, to deliver a lecture on the black cataract phaco go slow.
Thank you very much. I am thankful to Jagdish, also the Vishnu Patel sir, Sandip, Bhavik, all the Gujarat Ophthalmological Society. I want to thank all of you for unanimously supporting me for the Vice President election. Thank you very much for each and every person from the Gujarat. Thank you. So, my talk is about the hard cataract. So here, we all are doing. So there is no any financial interest. So few tips for the tackling the hard cataract. Can see the adequate visco is very important. So once you start, you should not complete. So you can put twice, thrice visco. The rexis should be larger. If the rexis is smaller, then the PC tear happens. And you can use the stop and chop will be better than the direct chop because that may, or you can use the divide and conquer. And here the fluidics and optimal phaco power is very important. Then you can see the trench. So can see the trends whenever we are doing the, so this is a, you can say the glow is very well, but it is a, can say like a, now you can say it is a cataract which is, now you see, it is not only one tip, but slightly larger, so that the tip can go in, and then it should be up to the periphery also and deep also. And when it is deep and up to the periphery, then it is possible to make the pieces. So whenever you are making the trench, so that is very important that it should be deep trench. And once it is deep trench, then you can go ahead and do the two pieces. And once you have made the two pieces, then there should not be any problem for the phacoemulsification. Now the making the rexis, you will see I am making the larger rexis. If you make it smaller, then all the forces come on the PC, not on the entire capsule. Otherwise, entire capsule, see here now, I am doing the chopping, and you can see the cataract is brown in color, though it was seen white outside. So again, you will see you will have to go and then engage. So your tip should be down and not straight. Slightly down tip, and once it buried inside the nucleus substance, then you can make the pieces, and it should be up to the center of the nucleus. If it is not up to the center of the nucleus, then the posterior pieces, which are rubbery pieces, those are not separated, and then you will, whenever you are taking the piece, then that piece will not come out. So if you make those pieces completely separated, then it is possible to remove this type of the cataract. And once the pieces are made, then it is not difficult to operate the case. So I think here where you can see the I completed the 4 pieces, and once you completed the 4 pieces, then there is no problem for the this one. Now you will see small pupil, and in that you will see this is a fibrous capsule. So whenever you are making, it should be mid-periphery. If you open in the center, then that will trouble you. And again you will see now, you can see the iris also. There is iris repulsion syndrome. So here you will have to operate in between. See what I am doing is, whenever the, and here you have to also take care of the, see here, my chopper I am using for the iris, prevention of the iris. And then you will see again, my trench is deep, larger. So once the trench deep and larger, then there is no any problem for this. Again you will see can you see this, the posterior fibers. Only thing is you will have to separate these fibers. If you separate these fibers, then the nucleus can be tackled very well. And here again you will see I am also taking care of the pupil, and you will see the pieces are made, and once you made the pieces, then separation of these 2 pieces are very, very important whenever you are tackling such type of the cataract. Otherwise this cataract will not come in your phaco tip, and you feel that what went wrong. Then in this case also, you always choose a cataract which is slightly whitish brown. And there you can go for here you will see I am just doing the chop. Can you see the direct chop? And here you will see the chop can be done directly. But here when you do the direct chop, then again you will have to see here to separate it properly and use the power, also the phaco power and your chopper properly. And once you use that, such type of cataract also can be chopped. But you do it after your experience. If I am doing it, you don't try to do it. Otherwise, you may have the problems whenever you are doing such type of the cataract. See here, again I am doing it and taking one piece like that. So again you can see I am using both torsional and longitudinal the power. You can see the fibrosis of the anterior capsule. I have made the rhexis. And after that now, again, I am doing the chopping. So you see here, I have buried the tip inside. So that should buried inside, and once you bury inside, then only you can make it separate. So your tip should go slightly downward and not only horizontal. So once you go in the substance of the nucleus, hard nucleus, then you can make it properly. The chop can be possible. But when the nucleus is black one, the direct chop we should avoid. There you can go for the stop and chop. But if it is a white element is seen, then the chopping is possible. So here you have seen the chopping is done, but the element, some of the tissue is in whitish. So here the chopping is possible. But if it is blackish one, we should definitely avoid it. Again you will see, I am going slightly downwards and then separating up to the center of the nucleus. And once you separate it up to the center of the nucleus, again you will see, and then I am supporting by the chopper, and the last piece when I am removing. So I am going slow so that surge will not trouble you. So here you will see very slowly I am just taking the pieces. So that completes the cataract. The only thing is that the stop and chop and direct chop technique can be used. The effective use of the ultrasound is very important. Experience. So if you are experienced, then only touch such type of cataract and always choose whatever is better in your hand. Thank you very much. Thank you.
Sir, very nice presentation. You have shown multiple videos, very informative video. Each cases look very easy in your hand. But I think that for the beginners, the first two things are more important, that before starting phacoemulsification, nucleus should rotate.
Yes.
And before starting emulsification of the segments, you should make able to make two pieces, at least two pieces.
Yes.
So because posterior plaque is there, and then start this phacoemulsification, otherwise bowel formation or some complication may be there. I will request Dr. Divyang sir to hand over the certificate, give certificate to the Rahane sir.
Lane sir, you showed small pupil. You have the experience with B1X or B2X? You showed small pupil phaco.
Small pupil phaco.
You have the experience with B1X, B2X in those cases?
I have not.
Sale?
No, what?
You have experience with B1X, B2X?
Pupil expander. He is asking about pupil expander.
BX.
Huh?
BX.
PXS.
BX.
Pupil expander.
No.
Small.
Expander. No, expander, I am using the iris hooks. I am not using the expander.
It's not an expander, sir. It's a liquid.
Yes, yes.
B1 is fluidic. B2 is slightly viscous.
Okay.
And it helps in pupillary dilatation during surgery.
Thank you. Now we are inviting Dr. Ragini Parikh Madam from Mumbai to deliver a talk on how to reduce the astigmatism in cases of SICS. That's really important topic, and it's really tricky also, because in SICS to manage the incisions and the astigmatisms are very, very tricky. So let's listen to him.
Thank you, Jignesh bhai. Respected Dr. Jagdish Rana sir, a big thank you today. Like Dr. Lahane sir said, thank you to you. You are sir's brother. But what you did and the whole of Gujarat did for Lahane sir is something that we will never forget. Respected Dr. Khamar sir, Dr. Jagdeep bhai, Dr. Narendra bhai, Dr. Divyang bhai, Dr. Bhaumik, Dr. Bhavik, Parth, my brother Arvind, everybody, Sitmir, the whole of the organizing committee. It's a pleasure to be here, especially because I'm a Gujarati, I'm a Kathiawadi. So it is always good to be here amongst family. So like Jignesh bhai said, that SICS is very, very important. I have done a huge number of SICS. I may be a primary phaco surgeon, but I feel that SICS is something that everybody should know. So, but you have to agree that there are problems in SICS. What happens in SICS is that the tunnel is large, like ECC, but you want it to mimic phacoemulsification. So as you can see over here, your tunnel is very big and you want to optimize the astigmatism. So what are the things that you have to consider? The anesthesia, which is different because you can do phaco under topical, but here you have to do it under local anesthesia. So we have to think whether it is possible. The post-operative course, the astigmatism, and what intraocular lenses to be used. So these are 4 points which we need to discuss. Now when we discuss the anesthesia, because we are making an incision in the sclera, we give peribulbar injection in SICS. The patient looks very good and comfortable in topical because we put drops, operate the patient, give them white glasses, and within the next 10 minutes, we send the patient home. But if we give a peribulbar anesthesia, the patient requires padding, and the patient needs to be, you remove the pad the next day. So the patient comes and tells you, ki, my friend got operated, usko to safed chashma, immediately started seeing and went home. So this is the first question that you have to answer, and whether topical anesthesia can be done. So this is the question that we need to answer. So manual small incision cataract surgery under topical anesthesia with intracameral lignocaine, and a study has been done where you can also do it with lignocaine jelly. So we have done some cases where we've been in the rural setup And yesterday when I was talking to Parth, he also does a lot of large volume surgery. He said if the patient is bilaterally blind, we never send them back. We do both the eyes at one camp because the patient will never come back after he sees with one eye. So what happens is that most of the times these patients come to you because they are unfit. And in a camp we are doing SICS, they are unfit, so should you postpone them? And even not fit, the anesthetist is scared to give even peribulbar anesthesia. So a subtenon's anesthesia or lignocaine jelly. So many things and topical, a combination of this does work, and we have done it. So you have to ask the patient to look lying down and looking down pre-surgery. So what are the causes of pain during surgery when if you are not giving an injection? So touching the iris, stretch on the zonules, sudden changes in the anterior chamber, and nucleus delivery. So these are the points that you have to be careful about to prevent the pain in the patient, especially the iris touch. If you are doing an iris-free surgery, even in topical, if you touch the iris or if you handle the iris, the patient will tell you that there is pain. So all these can be done in SICS if you are careful with these points. So as you can see over here, this is a video where you can see phaco on one side and you can see the SICS being done. So that's the first difference. So this is a corneal tunnel and this is a sclerocorneal tunnel. So this is the main difference. Now this difference will be causing the astigmatism in SICS, and that will cause the difference in the patient recovery and convalescence and the residual astigmatism. So this is the entry in both, but this is not responsible, the construction of a tunnel. So if you construct a tunnel properly following geometric incision, then the chances of astigmatism will be less. So square incisional geometry is very, very important to reduce the astigmatism in SICS. SICS and astigmatism go hand in hand, so some amount will be there. Now, as far as hydrodissection is concerned, it is the same. But one must remember that since the incision is small, the amount of fluid that you can inject in phaco will be a little less. Here the tunnel, if it is open, you can get away with a little more fluid. So here one must remember that this is hydro. So multiple point hydro, I would say for both, is safe. Because even though it is SICS, sometimes there can be a small PC defect or a rent, and hence one has to be very, very careful. Here you rotate the nucleus and bring it into the anterior chamber, and there you just rotate and keep it in the bag. So that is important. And what is important, what is the difference again in the IOL? So here a foldable IOL is put, and here a rigid intraocular lens is put. I know people do put in a foldable lens in SICS also, which can be done. But through a small incision, a rigid lens should not be put. So the lens opens here. Here the lens is dialed into the anterior chamber. It was done under BSS, as you can see, with the AC maintainer. So these are the different steps and the difference in SICS and phacoemulsification. As you can see once again that this is done under BSS. So the need for removing the visco in Blumenthal surgery is not there, and Sir does a visco-free Blumenthal cataract surgery. So what is the post-operative course of each? So what is the problem statement? Patient will always complain of post-operative pain and foreign body sensation. So this was always there in SICS patient. We take the formation and the replacement of a conjunctival flap very, we take it very relaxed. We don't take it very seriously. But if the wound is covered with the conjunctival flap properly, then the patient does not have any foreign body sensation. Since it is at 12 o'clock, it is covered by the upper lid. Many a times when we were taking rounds, it would be very difficult to find out, unless and until you retracted the upper lid, whether the patient had undergone phaco or SICS. So subconjunctival dexamethasone reduces post-operative inflammation and pain. Eye patch with topical, you may not pad or remove early, and you can start post-operative drops early. Refraction can be planned very early in phacoemulsification under topical, and I know surgeons operated by us or sir going to work and operating the next day, which we do not advise. So what is astigmatism? It is based on the length of the incision. 4 millimeter would be 1 diopter of astigmatism. So these are the various, so if the incision is very large, it would be 8 diopters. So one has to be very, very careful. You want an astigmatic free surgery. So you have to modify the incision position and tunnel to reduce the astigmatism, which is an inherent part of SICS. But even with phaco, every surgeon has at least a 0.5 diopter induced astigmatism, and that is why you tell the patient that we do not guarantee spectacle free vision, we guarantee spectacle independent vision. So superior incision versus superiotemporal incision. So superior incision induces the ATR astigmatism against the rule astigmatism, because and there will be lid pressure effects. It is near the visual axis and it induces more astigmatism. Whereas a superiotemporal incision will induce with the rule astigmatism. There are no pressure effects. It will be away from the visual axis. It will induce less astigmatism. But one must also remember that it is more open to the environment and more prone to problems during if there is any injury. So I personally feel that under the lid incision would be safer. Whether it is SICS or phaco, a proper preoperative workup with a proper autokeratometry, optical biometry. So now we all have IOL masters to give us the correct, the refractive power of the patient or the expected refractive status of the patient post-surgery. So whether it is SICS or phaco, a correct, thorough biometry, and I must tell you that I still do biometry in our workup. Do not rely at least one reading is done by me so that I know that there are no mistakes. Topography is very, very important in premium lenses. This is for phacoemulsification, but also in high cylinders. You will be surprised that so many patients have been operated without doing topography. Piggyback lenses have been put, and to the surprise, the patient had keratoconus. So topography is becoming increasingly a part of a routine workup in cataract surgery. So it provides the steep and flat axis. So you have to correlate the astigmatism with previous glasses, current refraction with the barometer if possible. A-scan, examining the A-scan report thoroughly, reading it, taking more readings if possible. I have seen patients, even if they rub their eyes 2 minutes before doing an IOL master, there will be some astigmatism. So dry eyes, simple things like breaking of the concentric circles on the autoref also can pick up dry eyes. It is so easy to pick up, so one has to be extremely careful. So you have to know which axis, what you are doing, taking time to study all this and then making your decision. So as you can see, how you can place your incisions for good results. And this is a tunnel surgery. So this is the formation of a conjunctival flap. One has to be very, very careful to make this correctly and to reposit it back, not to do too much of cautery so that there is no too much of scarring at the sclera. Making of the tunnel, which is a modified funnel and a modified frown. Properly constructing the tunnel in a triplanar incision, as you can see over here, is extremely important because it also provides the safety with respect to the surgery, with respect to endophthalmitis, and then the entry. Once you extend the incision, it should be extended when you go in and not when you come out. So that is very, very important. The pockets give you the space without increasing, and as you can see over here, this surgery we could do it with a very small incision, and this is correctly portrayed without. So So if you have to extend the tunnel, what you have to do is always extend it internally to reduce less astigmatism. So now here you can see we made the incision. The glide, so this is a video which is Dr. Lahane sir's. As you can see, the nucleus is very, very big, very hard. So if you have to extend the tunnel, it has to be, the pockets have to be extended without increasing the length so that the astigmatism is not compromised. As you can see that the pockets were deepened, which allows the nucleus to glide easily without increasing the length of the incision and hence will not compromise with the astigmatism. As you can see over here, the lens is extremely hard and that is why it had a problem to come out through a regular incision. Intraocular lenses, so can you implant premium IOLs? So that is the question. Yes, if you reduce the size of the incision and if you make it an astigmatism neutral surgery or if you reduce the amount of astigmatism, you can. Toric lenses over here also. As you can see, you have to do the Barrett calculator and the calculation. So it can be, but in young patients who have very, very small incisions, who have small central cataracts where you can get away with a smaller incision, you can do it. So this is the readings which show you the calculation, the astigmatism, the degree, and your axis. So to conclude, it can be, the outcomes in SICS can be made optimal with minimal modifications. You have to evaluate the patient properly with proper preoperative parameters and knowing your own surgical induced astigmatism, which is a very important tool. Bad endothelial count, black cataracts results in better and quieter postoperative outcomes with SICS. And I definitely believe this. It is a premium surgery. We should not feel that it is inferior because it's better to have good results with SICS than to have a poor endothelium or a nucleus in the vitreous with phaco. And it can be modified to give better results. Thank you so much for the opportunity to speak. And thank you so much for the invite and the honor. Thank you so much, sir.
Thank you. Thank you so much, ma'am, for teaching us the basics. Yeah. So it is very, very important for, definitely, ma'am, and it is always back to basics, and each and every is a very good faculty, but they must be knowing SICS at least for any kind of complicated cases, ma'am. Thank you so much, ma'am. I would like to invite Dr. Narendra Verma, sir, to hand over the certificate to ma'am. Our next talk is Dr. Jitendra Vidani. He will be talking on phaco in the soft cataract. Thank you.
Madam, you have the data of endothelial loss. Madam, yes, you have the data of endothelial loss in phaco surgery and SIS.
So, since we were in a medical college, we had done a study where the endothelial loss will definitely be more in phaco than in SICS.
It's wrong.
Because of the, there will be more endothelial loss in phaco emulsification than SICS because of the fluidics, because of the ultrasonic allergy and the heat and the time. Yes, sir. So there will be more endothelial loss in phaco emulsification surgery than in SICS because
Why
of
phaco surgeons come in? Sale. Why sale? Idhar sun yaar. There is more endothelial loss in phaco surgery than SICS. Is it true?
Definitely, sir, because of a poor cornea will definitely requires good endothelial count before proceeding for the phaco. So any complicated cornea will be, SICS is a good choice compared to the phaco, for sure.
SICS leads to rubbing of the...
But in particular that case, we are talking about particular that case. So person to person, it may vary.
Both patients, if you suspect a patient of having a crocodile shagreen or corneal gutte, it is now better to do a specular microscopy and proceed with viscoelastics which protect the endothelium, both in SICS and in phaco. And sir, the techniques by which you are removing the cornea by the nucleus So there are some techniques which scrape the nucleus on the endothelium, but it is not only the physical scraping, but the amount of heat generated by the ultrasonic movement and the fluidics of the phaco, which cause the endothelial loss. In fact, even the implantation of an intraocular lens, any material of intraocular lens, if it touches the endothelial cell, there will be immediate de-roofing of the cell, and that cell will die. So at every stage, I mean, when I was learning with Lahane sir and my teacher R.C. Patel sir, and sir always, so they always taught me from day one that you have to treat the cornea like God, because it can never be replaced. So one has to be careful for every patient, not only a patient with an compromised endothelium, but for every patient, because they may look good the next day, but 10 years down the line, the patient will have a decompensated cornea because of a poor surgery.
May I answer this question? Yeah. So the higher order of evidences are systematic meta-analysis. So I have gone through 3 such meta-analysis, and there was no significant p-value difference. One done by Dr. Parikshit Gogate between the endothelial cell loss, even when the nucleus was denser, while operating through phaco or SICS. There was no significant p-value difference.
If so, then why insist on SICS in low endothelial count?
Phaco...
He insisted.
Phaco has its own advantages, no doubt about it, because of the smaller incision size. If we are making a large incision of 8 millimeter, so that gives an astigmatism of up to 8 diopter, right? So astigmatism and the healing, corneal healing, so that will always be better in phaco.
Thank you. Dr. Jitendra Vedani, yes, now you can start your talk.
If pre-operative there is no any complication, and post-operative cornea is clear, there is no need of endothelial cell count also.
Now I will invite Dr. Jitendra Vedani for his talk on phaco in soft cataract.
Sound, eh? Okay, so good evening, everyone. I'll be speaking on the last topic for the session. So my topic is phaco in soft cataracts. Before starting, I would like to show you 2 videos. So this was day 1 when I started learning the guitar. And after like zillion years, this was one day. So all I'm trying to say is whether it's music or it's surgery, Rome was not built in a day. So we'll start with cases now. This was case 1, 33-year-old male patient, right eye amblyopia with PSC grade 1 cataract. Right eye vision was finger counting 3 meters. Left eye vision was 624. Left eye was operated 1.5 years back at our center. GVP consent was taken for amblyopia. So as we can see, I was aiming for a large rhexis. I wanted this rhexis to be on the larger side, 5 to 5.5 mm, and I was successful in doing that. And then I created the main port, and then I did a hydrodissection. And as soon as I go and do the hydrodissection and delineation, the nucleus pops out. And then I don't really try and, displace the nucleus inside, because it's already popped out. So I just go in with the phaco probe and emulsify it in the anterior chamber. And as we can see, it's a very soft cataract, so I didn't feel like that I can, chop the nucleus. And then the rest of the surgery was really easy. Moving on to the next case, 60-year-old female patient. She was diabetic and hypertensive since 10 years. Right eye was operated 1 year back. Right eye vision was 6.6 post-cataract surgery. Left eye vision was 6.9, and the grade of cataract was 1++. That is like a fairly soft cataract. But sometimes, as we see that on the slit lamp, it appears a soft cataract. But when we go ahead and do the surgery, it seemed like a choppable cataract. So I kind of try and divide the nucleus into 2 parts, and I'm able to do it successfully. And there are 2 heminuclei that I'm able to make. And then I'm trying to divide it even further. And then I'm even successful in doing that. But as you can see, there's a lot of cheese wiring that is happening. But as soon as one piece comes out, the rest of the surgery becomes easy. So all I'm trying to do is I change the technique and switch my technique to trench and divide. And now the plate has been separated. There are two equal heminuclei. One, I just need to get out one piece outside the bag and the rest of the surgery will become easy. That's what I did in this case. Case 3, 51 years old male patient, right eye grade 1 cataract, right eye vision was 624, left eye vision was 618 parts. IL power calculated was plus 20.5 diopters. So as we can see, I've done a hydrodissection as well as a delineation. I'm again attempting a chopping with low parameters, but I'm not able to do it. And there's a lot of cheese wiring that's happened. So again, I'll just divide it manually. And then as soon as, there are two heminuclei, as soon as the one heminuclei comes out of the bag, the rest of the surgery becomes really easy. And that's what I did in this case. And then the epinuclear plate was also removed with the phacoprobe itself. Moving on to the next case, 44 years old female patient, right eye vision was 624, left eye vision was 69. Right eye it appeared like a pseudo posterior polar on the slit lamp, and the IOL power was plus 17 diopters. So I wanted to treat this like a posterior polar cataract. So what I did was I did a little bit of sculpting, and then I don't want the antechamber too shallow, that's why I put visco. And then what I'm doing right now is described by Dr. Bhavik Zala, which is called the inside-out technique. And after that, the case becomes really simple because it divides the nucleus into multiple parts, and then the nucleus and the rest of the epinuclear plate can be removed very easily. And that's it. The epinuclear plate is left, and then that also is removed with the phacoprobe. This is the removal of the cortex. But I don't want the chamber too shallow. That's why what I did was a visco fluid exchange. This was the article published by Dr. Bhavik Zala, sir. Case 5, 46 years old female patient, both eye vision 624, improving to 6.9 with pinhole. Left eye was grade 1 to 2 PSC cataract. IOL power was plus 25.5 diopters. So here, what I'm going to show you is that it's a really tricky situation because the iris is floppy. It's trying to come out of the main port. The pupil is going on the smaller side, and it's just that you're stuck. And what I call this is a dish technique. I mean, I didn't devise it, but Dr. Saurabh Patwardhan calls it do it somehow technique. So I'm just trying to prolapse the nucleus somehow in the anterior chamber so that I can emulsify it and get done with the case. Because as you can see, the cornea is also really on the hazy side. So I'm able to successfully then prolapse it, and the rest of the case becomes easy because one piece comes out, and then the rest of the case you can manage. So soft cataracts, myopoles, soft is harder. You need to accept it first of all. Do an appropriate sized rhexis. You would use a good dispersive OVD, Viscoat in my case. That is what I use in all my cases, no financial interest. To protect the endothelium, it is a very good substance by Alcon. And also you need to use a good cohesive OVD to protect the posterior capsule. Hydrodelineation is a must. Have multiple techniques in your armamentarium. Always attempt chopping first with low parameters. If that doesn't happen, you need to switch your technique to trench and divide. If that doesn't happen, there is no shame, absolutely no shame in hydroprolapsing the nucleus in anterior chamber and eating it out. Inside out can be attempted not only in PPCs, but also in soft cataracts, and it works very well in my experience. If nothing else works, dish technique is the ultimate technique. And last but not the least, have patience and keep in mind it's not over until it's over. Thank you.
Thank you so much, Jitendra. So I want to add one point. In such cases, what is helpful for me is, in spite of doing divide and conquer and direct chops like chopping technique, we can do 4-quadrant divide and conquer. So that will be very easier to chop that small pieces, and that small pieces will be easily removable. So in spite of doing stop and chop, this will be very helpful for you. I would like to invite Dr. Ragini ma'am to hand over the certificate to Dr. Jitendra. I would like to
request
invite
all the
all the
speakers to
speakers.
come on the dais for the group photo. Yes.
Yeah. Yes. Next session is
Sir, Dr. Lane, sir.
group photo.
Dr. Saloni.
Thank you.
Thank you so much, everyone. So now we are moving to the session 4, that is my healthcare session. I would like to invite Dr. Amit Shah, sir, if he is available, Dr. Mukesh Patel, Dr. Prafula Kumar Marana, Dr. Nutan Shah, Dr. Shail Vashawda, Dr. Dikesh Goyal to run the next session. I will
मेरा यहाँ पे दे रहा हूँ, मेरा यहाँ पे दे रहा हूँ, इधर ले लो। कौन सा नंबर का है? सर वो उसमें से उसमें खोल है, उसमें चल उस लैपटॉप में ना ये था क्लाउडी क्लाउडी हो रहा अच्छा बहुत बहुत ये आगे बोल कुछ नहीं करो सही था कल का ना कुछ नहीं दिखा आगे 10 मिनट क्या कुछ नहीं दिखा देखिए ऊपर हाँ जो हाँ 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 बहुत एकदम लंगी भी था क्लाउडी भी ये देखिए ये दिख नहीं रहा है क्लाउडी कल हम गए थे जैसे ये पूरा पूरा
Good afternoon all. First of all, thank you AGOC team for inviting me here. So my topic today is phacoemulsification in corneal opacity. Myself, Dr. Praful Maharana, I am an additional professor at AIMS New Delhi, RP Center, and current secretary of Delhi Ophthalmological Society. So when you are dealing with a patient who has corneal opacity and cataract, there are 3 major challenges. The first, how to calculate the IOL power. Second, phacoemulsification, the biggest challenge being visualization. And third, post-op visual rehabilitation. So I'll be dealing largely with the surgical part. So this is a review article which we published long time back in JCRS. If you want to go through it detail, we have written how to approach such cases. So my PPT is basically a gist of that only. So there are basically 2 approaches when you are having a patient with corneal opacity and cataract. So one, you combine it with keratoplasty. You change the opacified cornea with a clearer donor cornea and then do the surgery. The second, you go ahead with cataract surgery alone. But remember, when you are choosing to go ahead with cataract surgery alone, now you have to be careful about patient selection. Don't jump into all the patients. If the patient is having a small peripheral opacity and patient is not a case of suitable for keratoplasty, and always check for visual potential, whether the patient is going to gain anything after cataract surgery or not. So how are you going to know that? There are different ways. Get a dilated visual acuity. If you have LI or PAM, go for that. And if you don't have any instrument with you, what you can do is just take a good history. If the patient is having opacity since a long time and there is a clear-cut history of recent drop in visual acuity, then the most likely the patient may benefit out of cataract surgery. There are certain aids to facilitate your surgery. So I'll go one by one. First, positioning the patient. If you see this picture, if the patient is having an inferior corneal opacity, it's always better to go for a temporal phaco. If the patient is having a nasal corneal opacity, it's always good to go for a superior phaco. So that is one. Microscope illumination. You can always switch off the light of the OR and only use your coaxial illumination. So that will give you good illumination. OVDs or Vigilon or viscoelastic. When you put viscoelastic on corneal surface, that increases the magnification transiently and also improves the clarity. So you should be putting viscoelastic again and again on your corneal surface. Ophthalmic dyes like trypan blue, that's a must in all the cases. Because if you stay in the capsule, that makes your life quite easy. Ophthalmic tools, when I say ophthalmic tools means you should have iris hook, you should have pupillary dilators, you should have microrhexis forceps, microrhexis Caesar. I'll show you in one of my cases. Endo illuminators, I have not that much experience of using it, but yes, in extreme cases, they are useful. Now with pupilloplasty, so always remember to adjust your pupil diameter depending on the size of the opacity and location of the opacity. So I'll go to my first video. Here it was a case of post-pterygium excision corneal ectasia as well as scar. I hope you can appreciate here, there is a superficial haze and the central part was ectatic. Always go for a clear corneal or limbal incision depending on the corneal thinning. Always stay in the capsule. When you are doing rhexis, remember, always try to use a rhexis forceps. And when you are crossing the opacified area, don't leave the flap. Just go in one go. If you leave the flap, you may struggle to find the flap again. Hydrodissection is a must because whatever maneuver you are going to do, that will be in the clearer corneal area. So you have to rotate the nucleus again and again. So hydrodissection and nuclear rotation is must. Viscoelastic, as I said, when you put it, it transiently improves the visualization. Chopping technique, you go ahead with whichever technique you are comfortable with, direct chop, vertical chop, horizontal chop. So that's not an issue. But when you are doing this, remember, because of the corneal scarring, there will be a lot of scattering and it may be difficult to judge the exact depth where the phaco probe is. So you have to do a slow and low phaco. Lower the parameter, go slow by slow, and don't do it in the vago phaco, in the back phaco, rather do it at the pupillary plane. So next, I'll show you a little difficult case. It was a diabetic cataract, it was an adherent leukoma, iris was stuck, and there was posterior synechia. So here comes the role of different tools that you must have in your OR. Trypan blue staining is a must in all such cases, as I said earlier. But here you can see I'm releasing the synechia using a combination of viscoelastic and some blunt spatula. And these are the tools that you must have while dealing with such cases to dilate the pupil. Rhexis was not possible because it was a fibrotic capsule, so I had to use microrhexis forceps and scissors to cut and complete the rhexis. So all these tools you must have in your OR. Once you achieve a rhexis, functionable rhexis, then the next thing is hydrodissection and nucleus rotation. And this is an important point. Suppose midway surgery you realize the visibility is not that good, you can always go ahead and restain the capsule. While doing chopping, you have to be a little bit careful in such cases. The PC may be anterior and you may rupture the PC. Rest of the surgery steps are similar to a routine phacoemulsification. So in this case, I put a 3-piece because the rhexis was not a circular one and it was more like a tommy. 2 short video, then I'll conclude. When you're dealing with peripheral corneal opacity, remember such, you can see when I'm trying to go in, this area is getting buckled or almost folded. In such patient, always try to put a suture in the end or else the wound may leak. Rest steps are as I discussed in my first case. Then one different problem with corneal opacity, there may be corneal edema along with opacity, like cases of Fuchs dystrophy. In such patients, the basic steps are same, but here I would tell you one thing called phaco in situ. Phaco in situ means the moment you divide a nucleus in multiple pies, then try to take out each pie. Don't wait that I'll divide in 6 pieces and then take one by one. One division, 1 piece, take it out. The second division, second piece, take it out. So this is what I wanted to show in this video. So all in all, you can go ahead, we can do phaco in corneal opacity with proper selection and little bit careful technique. Pupilloplasty, if you adjust the pupil, there was a study by Miller et al. Well, they found that the vision can improve till 2013. Post-op, remember, always counsel the patient. This is not the only intervention. Subsequently, there may be glaucoma, there may be infection, there may be recurrence of viral keratitis. So you have to counsel the patient properly. ILPAR, it's a completely different lecture, I guess. But remember, in such cases, because of opacity, optical biometer is not useful. Always go for immersion if you have, or simple A scan. Keratometry, always prefer a tomography. So thank you so much. These are my books. A lot of students are here. I hope you follow my book. If there are any reviews, do let me know. And I came here especially to thank you, all of you, because you may not be knowing your midterm was postponed from 15 to 21st because at Delhi Ophthalmological Society we had our annual conference. And thank you to Parth and Sir and all the AGOC office bearer for postponing your conference by 1 week. And we did a great job at annual DOS. And thank you AGOC for that. Thank you so much.
Thank you. Please collect your certificate, Dr. Maharana. Shail will. Next speaker is Dr. Rushil Ambani, very young guy from Ahmedabad, and he will be speaking on dry eye decoded. So nowadays, dry eye problem is increasing because of computer, mobile, laptop use, even in school.
Good afternoon, everyone, and thank you for giving me a chance to speak on this stage. We'll be discussing upon a few interesting cases relating to dry eye. So without further ado, the first case, she is a 45-year-old female, had a complaint of gritty sensation in both her eyes since the past 3 years. Schirmer scores were 9 mm and 10 millimeters. There was some corneal haze, dry spots, and some pannus. Some mild congestion and tear film breakup time was also decreased. So at this juncture, I would just like to reiterate that the tear film breakup time is more of a marker of an evaporative type of a dry eye picture, while the other markers are of an aqueous deficiency or a mixed picture. So there was a bit of confusion regarding the cause of the dry eye. So what were we missing here? So it is the DATS. DATS is the direct visualization of aqueous tear secretion. So to perform the DATS, you need to ask the patient to look down and pull the lid in the opposite direction. Stain directly the surface of the lacrimal gland with the fluorescein stain and look for the number of open glands. In a normal scenario, around 2 to 4 glands should be open with a steady flow. So this female had a DATS of 1 gland open and also had a history of dry mouth, which led us to a diagnosis of a Sjogren type of a picture. We did a rheumatological workup and also had a rheumatological opinion. But which medicine should we start in this case? So every other day we are bombarded with a lot of medicines from the pharmaceutical guys, like different forms, like carboxymethylcellulose, sodium hyaluronate, trehalose. We don't know which medicine to use. So for the case of simplicity, I like to divide the medicines into 3 different groups. The first one is the carboxymethylcellulose type of medicines, CMC 0.5% or 1%. I try to use them for aqueous deficiency type of a dry eye picture, since they are mainly the replacement for the aqueous part of the tear film. Sodium hyaluronate eye drops are more of a lipid deficiency type of a dry eye picture. They are some replenishment for the outer layer, the lipid layer. And the third group is the preservative-free medicines, which is the sodium hyaluronate preservative-free and the other drugs. They are more useful in case of a DICC type of a picture, which is a drug-induced cicatrizing conjunctivitis. So for this woman, since she had a primary aqueous deficiency, we tried using carboxymethylcellulose and she is doing good. The second case is of a 54-year-old female. She had both eye pulling sensation in her eyes since 1 week. If we see closely at the left side picture, we can easily see the anterior blepharitis, which is fulminant in the left eye, especially in the upper lid. She also had a history of similar episodes in the past. We took samples for the eyelashes. If we can see, there are fine cylindrical attachments on the eyelashes. We need to plug them and look them under a drop of 10% KOH with a cover slip to see live or dead Demodex follicularis. So diagnosed as a case of Demodex blepharitis. As we know, apart from the blepharitis type of a picture, the management of Demodex blepharitis includes the use of tea tree oil in the form of wipes, or we can mix some amount of tea tree oil with coconut oil in a 50-50 combination and give it to the patient. So the next case again showed up with this type of a picture with a normal Schirmer's value, no meibomitis, and a chronic congestion history. There was some limbal stem cell deficiency in the right eye, as we can see. On taking detailed history, patient had a history of work in a cement factory and had a history of constant chemical exposure. So we diagnosed this as a case of a constant chemical exposure causing dry eye disease. Since there is some mild LSCD, we need to aggressively manage the dry eye type of a picture and control the inflammation with steroids or calcineurin inhibitors like cyclosporine. And it's also of an evaporative dry eye due to the constant toxicity of the chemical induced, so we will prefer sodium hyaluronate based eye medications. So another case of a 58-year-old female using multiple anti-glaucoma medications, having conjunctival congestion, inferior symblepharon, and some conjunctival fibrosis. Whenever I see such a picture, I tend to move away from the slit lamp and look at a broader picture. And we can see easily the skin excoriation, which are classical markers of drug-induced lesion. So in this case, we would prefer the third category of drugs, which are the preservative-free medications, and switch over the patient to preservative-free anti-glaucomas. Control the inflammation with either topical steroids or plus minus cyclosporine. So to summarize, CMC type of a group in aqueous deficiency dry eye picture. Do not forget that these patients might have an underlying rheumatological manifestation. So it is important to have a rheumatological opinion for these cases. The second group of patients with evaporative dry eye need to be addressed with sodium hyaluronate type of medications, and the preservative-free are to be reserved for the patients with DICC. History taking goes a long way in managing the patients of dry eye. Check Schirmer's and other methods of dry eye detection, use of etiology-specific lubricants and adjuvants as and when required, and to detect subtle signs of chronic cicatrization and treat or refer accordingly before the severity increases. Thank you for a patient listening.
Rusil, I came across a news article. I don't know whether you came across it or not. A kid had a 35 lice Jew in eyelashes, each eye.
Yes.
So how would you have treated that?
Yes. So for the, I think the news article which we are referring to, there were some of the lice even in the on the ocular surface, not just on the eyelashes.
It was in eyelashes.
Yeah. So for the eyelashes, I would just, if there are big lice, then we can just pluck it out along with the lash margins and have an examination. Another option is using, after instilling Paracane, we can use some oil drops to get all those lice out.
How far the sulfur shampoo help?
Sorry, sir?
Sulfur shampoo.
I don't have an experience with using the sulfur shampoo.
There is Selsun's a company, Selsun, usually used for dandruff and lice, sulfur shampoos.
Okay.
So once you take a bath, it's all gone, I suppose.
No.
Thank you, Rusil. I have this side.
Sorry.
So nice points. But about the use of lubricating drops,
yes,
you rightly highlighted all the drops are not useful for all cases. So just for the audience, all the TS supplement, they have two important properties. One is mucoadhesive, the other is humectant. Humectant means they tend to stay and absorb more and more water. So as you rightly said, CMC has mucoadhesive property only. Sodium hyaluronate had mucoadhesive plus this humectant and plus some epithelial healing promoting factors also. And third group is all this tear supplement along with some other electrolytes like trehalose or carnitine, all this thing. So when you say it's a simple case of dry eye, aqueous deficit, yes, CMC, sodium for both works. But when you say it's an evaporative dry eye, the lipid layer is deficit, sodium hyaluronate alone may not be useful. It will definitely help, but you have to prefer something which has some lipid component like trehalose, that group of drugs you have to use. And when you are dealing with some more severe cases, you can choose more options like some teardrop, they have antioxidant, some are minerals, so that goes on like as the severity increases. And whenever you feel there is some inflammation, like your case 1, right? Whenever there is occurrence, there will be surface inflammation. Steroid or immunomodulators is a must, and the tear supplement has to be something that has some anti-inflammatory properties also. So CMC 1% or trehalose, they do have some anti-inflammatory property, so that can be preferred in such cases. But you rightly said history is very important. If you see a case of dry eye, no explainable reason, middle-aged female, always ask whether there is dryness in throat or other parts also. Thank you.
Definitely. Thank you, sir. Thank you.
Sushil, please collect your certificate from Dr. Mukesh Bhai. Next speaker is Dr. Sonal Agrawal. She will be speaking on corneal ulcers. This side.
I'm audible now. The today presentation is corneal ulcer. The objectives of my presentation are to review the basics of causes and clinical features of corneal ulcer, to understand the medical and surgical management, and to get acquainted with the recent advances in corneal ulcer, management of corneal ulcer. Corneal ulcer is basically necrosis, inflammation, and excavation of corneal tissue. Its appropriate treatment and instant diagnosis very crucial. But due to various factors, like patients are farmers, laborers from rural area, their only one eye is affected, the presentation of the patient are delayed, and thus corneal ulcer exists as a silent epidemic in our society. The etiological classification of the corneal ulcer is, it can be infective and non-infective. Infective can be due to pathogens like bacterial, viral, fungal, and parasitic, protozoal. Non-infective can be due to trauma, autoimmune, neurotrophic, and due to allergic conditions. The most important predisposing factor for corneal ulcer is breach in the corneal epithelium. Corneal ulcer patient present with pain, watering, photophobia, redness, decreased vision, and discharge of the eye. Bacterial corneal ulcer is considered the most common cause of corneal ulcer in the world. It progresses rapidly and present with dense infiltrate. Most common pathogens are staph, strep, and pseudomonas. But in case of India and also Gujarat, fungal corneal ulcer is equally significant. Common pathogens are fusarium and aspergillus. Typical clinical feature is not always present, but history of trauma with the vegetative matter, these feathery margins, satellite lesions, dull, dry-looking ulcer, pigmented lesions suggest fungal corneal ulcer. Pythium corneal ulcers, they mimic very much like fungal corneal ulcer, but their tentacles are smaller than the feathery margins of the fungal corneal ulcer, and they progress very rapidly. Acanthamoeba corneal ulcers, they are also known as ring ulcers, but the pathognomic presentation is this perineuritis and limbitis. They involve limbus very early. Another very common corneal ulcers in the world is viral due to virus. Most common is herpes simplex and zoster. The presentation is dendritic and geographical, and they also cause neurotrophic ulcers. Coming to the investigations part, After careful clinical history and slit lamp examination, fluorescein staining is done to document the size and location of the corneal ulcer. Corneal scraping helps in diagnosis by staining and also debulking the infiltrates. To decide on the culture, 3-to-1 rule is used. Like if the corneal ulcer is within 3 millimeter of the central of the cornea, size is more than 2 millimeter, and anterior chamber cells are more than +1. Newer diagnostic tools like in vitro confocal microscopy are very handy, non-invasive. These first A and B are the strains of the fungal hyphae seen, and in the C, Acanthamoeba cysta seen. They are not very, confocal microscopy is not very helpful in case of bacterial corneal ulcers because the pathogen size is very small to be detected. Anterior segment OCT, wherever feasible, helps to document the depth of the corneal ulcer. It also helps to monitor the progression of the ulcer and differentiate between non-infective and infective ulcers according to the infiltrates, the hyperreflectivity seen. Management for antimicrobials. In case of bacterial ulcers, we can start with broad spectrum empirical treatment with fluoroquinolones. In cases of severe corneal bacterial ulcers, fortified cephalosporins and aminoglycosides are started. For antifungals, drug of choice is netamycin. If needed, voriconazole and amphotericin B, locally and systemic, can be added. Pythium does not contain ergosterol cell wall, so we have to give linezolid. Acanthamoeba, biguanides and diaminidines are available, but they respond very slowly and we have to be very patient. For months, the treatment has to be continued. In case of viruses, acyclovir is drug of choice, systemic and local. Along with the antimicrobials, supportive treatment is equally important. Cycloplegics are very crucial, and analgesics and anti-glaucoma medicines are needed. To promote healing, doxycycline and vitamin C is added. In spite of medical management, if the ulcer progresses, in cases of small perforation, cyanoacrylate glue with BCL are used. If it is non-infectious and corneal thinning is present, amniotic membrane transplant and conjunctival graft can be used. Tarsorrhaphy is helpful in neurotrophic and ocular surface disorders. In spite of our most aggressive, appropriate, targeted treatment, if the fungal ulcer continues, therapeutic keratoplasty should be planned on time. There are high chances of failure, but our target is not to save the site, but to get a quiet eye. We should be careful that while removing the corneal tissue, 0.5 to 1 mm the normal cornea should be removed, and the anterior chamber should be washed copiously with the antimicrobials. Newer treatment modalities are coming, like newer cephalosporins, colistin, for antifungals, echinocandins are there. Photodynamic therapy, basically photoactivated chemicals, they particularly target the pathogen-laden cells, thus sparing the normal corneal tissue. So they are also very helpful. Rosuvastatin is a statin which helps in wound healing. When it is a novel drug delivery system, when it is delivered with the help of nanofibrous patches, a constant delivery of the drug is available at the site of ulcer. Photoactivated chromophores for keratitis, cornea cross-linking is a novel technique. The reactive oxygen species created by this technique is with the help of UVA rays. They damage the pathogen-laden cells. The photoactivated chromophores, they damage the chromosomes of the pathogen. And the cross-linking created by the for the corneal stroma, they increase the strength of the cornea, thus preventing the degeneration. Bioengineered tissues are very helpful compared to the conventional tissue transplant.
અમે નહોતા સહન કરી શકતા એટલો એને દુખાવો થતો હતો.
And infection is less. To summarize, take-home message: there is no substitute for proper clinical history and examination. Proper slit lamp examination and documentation helps in taking the clinical decision. Timely and organ-specific treatment is very crucial. Our target of the treatment is not only to control the infection, but also to control the inflammation and promote the wound healing, like the newer techniques of cross-linking. even if the antimicrobials are not
કરંટના
given, just by giving the
ઝટકા
cross-linking,
અસહ્ય
we can
હું પાણી
save the
બી
eye.
ના પી શકું
Surgical
મને
intervention is
જે
not the last
અસહ્ય પીડા
resort.
હતી લગભગ
It
દોઢ
can
બે
be
બે એક
sight-saving
વર્ષથી
if done on
હતી
time.
જ અને હું
And newer
એમાંથી
modalities
2
like
વર્ષથી પસાર
cross-linking
થઈ રહી હતી
bioengineered tissues
અને
are
દુખાવો
really
થતો
handy.
તો એ અવાજથી આમ
Thank
બહુ
you.
અમને
I would like
અમે નહોતા સહન
and
કરી
especially
શકતા
the
એટલો એને દુખાવો
AGOs
થતો
for
હતો
giving me
એ
this
અમે
opportunity.
એને એવી
Thank you,
તકલીફમાં
Dr.
જોઈ
Sonal.
છે
It's
કે
very difficult to cover
એમ
the entire
લાગે
corneal
કે
ulcer
હવે આનું શું
in
થશે
7
કોઈ ઇલાજ
minutes, and
થશે
you really did a great job. And one thing I think very important, because there are a lot of practitioners are here, when would you prefer single fluoroquinolone therapy vis-a-vis combination drugs of concentrated of like 5% Cefa and 1.4%
So we've
Toba?
taken the scraping and we are waiting for the result. We can go for fluoroquinolone therapy. And fortifieds are to be added if we, and the dosing is very important, very frequent dosing. If still we see the response is not there, then fortified drops are made next day.
So it's very important for as a practitioner, you know, we are at institute, so we do have microbiology setup with us. But if you don't have a microbiology setup and you are dealing with a corneal ulcer and you don't have a pharmacy that can give you concentrated drops like 5% cefazolin or 1.4% tobramycin, what you can do is you can follow the AO guidelines. AO guidelines suggest any ulcer which is less than 2 mm size and not involving the visual axis, you can simply start single monotherapy with fluoroquinolones like Vigamox, or nowadays levofloxacin is there 1.5%. But if the ulcer is bigger, larger and involve the central, you have to do a scraping. So if you don't have that facility, it's always good to refer to a center where corneal scraping and microscopy is available. That as a practitioner, all of us should remember. And one thing that you said, even Shale and me both are, what is that rosuvastatin? Is that something new?
Sir, which the net says it is available in India also.
Use the mic.
Yes, sir. This is reference from the net, no personal experience. The statin group, it promotes wound healing. And the experiment is done on rat. That I got 2-3. When I search for in India, it is saying that it is available in India, but I have not cross-checked it.
So rosuvastatin promotes healing, that you
It
mentioned.
promotes wound healing.
Wound healing, okay.
Statin.
Thank you.
Thank you, madam. I request Dr. Hitesh Ramanuj to give you a certificate. Our next presenter is the Dr. Harsita Saxena. On severe dry eye, corneal manifestation, systemic association.
A very good afternoon to everyone. Today I'll be speaking about severe dry eye disease and its systemic association and corneal manifestation. So to start with, severe dry eye is also known as severe dry eye disease, and severe DED is often more than a localized ocular surface disorder. So it can be a manifestation because of underlying systemic condition, identifying which is essential for diagnosing the accurate diagnosis, comprehensive management, and it also improves the patient outcomes on the basis of severity. So some of the key systemic association of severe dry eye are autoimmune disorders like Sjogren's syndrome, which are primary and secondary, rheumatoid arthritis, SLE, sarcoidosis, endocrine metabolic disorders like thyroid eye disease, diabetes mellitus, then dermatological like rosacea and atopic dermatitis, then neurological conditions like Parkinson's and MS, Bell's palsy. Also, it has been seen due to drug-induced like antihistamines and antidepressant being the most common ones. It can also be due to the hormonal changes like mostly seen in the menopausal stages and due to vitamin A deficiency, then also in the graft versus host diseases. Then to understand how should we proceed with the clinical workup in such condition, so we should always take a detailed medical history and systemic symptoms history should be taken. Then all the ocular tests like Schirmer's, TBOT and OSTI scoring should be done. Then blood tests which helps in identifying such conditions are some of the important ones are like ANA, anti-nuclear antibodies, then RF factor, SSA and SSB findings. Then thyroid panel has to be checked, and also the HbA1c. Then we can, to rule out condition like Sjogren's, we can go for the minor salivary gland biopsy. And also, we'll need the interdisciplinary consultation for the rheumatology department. Then the clinical relevance of this is, so early detection of systemic diseases via eye symptoms. It helps us in preventing the vision-threatening complications, also guides in systemic treatments, like if we have to start immunosuppressant or any hormone therapy. Also, it supports the holistic and patient-centered care. So it overall helps in relieving the symptoms of the patient. So just to describe a little bit about the lacrimal functional unit. So it's a complex reflex network which actually connects the sensory tissue and secretory gland that provides a homeostasis on the ocular surface. So the ocular surface tissues composed like cornea, corneal limbus, conjunctival and conjunctival blood vessels and eyelids. So this is tightly controlled by the neural inputs. Also, any subconscious stimulation of the corneal nerve ending triggers the afferent impulses through the ophthalmic branch of the trigeminal nerve. So that integrates the central nervous system, and the paraspinal sympathetic tracts in turn generates the efferent secretomotor impulses that stimulate the secretion of healthy tear film. So this is a little bit about the functional unit of the lacrimal functional unit. So just to see various triggering factors like environmental, microbiological, endogenous stress, and localization genetic factors that leads to triggering of this LFU dysfunction, and an acute inflammatory event that initiate the inflammatory circles of chronic dry eye. This is the classification, how we classify the acute deficient dry eye into Sjogren's syndrome and non-Sjogren's syndrome. And in turn, Sjogren's syndrome is divided into primary and secondary. Also, non-Sjogren into primary, or it can be due to any obstruction of the lacrimal gland disease like SGS, GVHD, and mucus pemphigoid and reflex hyposecretion. So just to enumerate some of the differentiating features of the Sjogren and non-Sjogren ADD. So Sjogren is an autoimmune, whereas in non-Sjogren it is an autoimmune, non-autoimmune condition. And there is a lymphocyte infiltration is seen in the lacrimal gland damage. And it is, we'll be able to find the positive SSA and SSB in Sjogren condition. And also there will be a patient will be having the symptoms of dry mouth and other symptoms of Sjogren's. In the patient will be having complaints, and onset is usually, it is seen gradual and progressive, whereas in non-Sjogren it is variable. So coming on to the dry eye and its relation with the rheumatoid arthritis. As rheumatoid arthritis, it is more common in females, and its association is seen with HLA-DR4, and there is an increase in the cytokine Th17. So diagnosis of RA is based on the joint involvement, symptom duration, serum studies like anti-CCP, and radiograph also helps, like there will be deformities which can be seen in the joints, and differential of CBC, CRP will be able to see. So this is some of the how the what all incidents has been seen with the association of dry eye with rheumatoid arthritis is 5 to 17%, and these are some of the ocular manifestations like episcleritis, scleritis, PUK, scleromalacia. Then defining, these are some of the severity features of the dry eye according to modified TFOS Dewey's classification. So as we all know, so I'll not be going into the details of this. Now coming on to the corneal manifestations which commonly see in the dry eye, severe dry eye conditions like punctate epithelial erosion are seen, which are mostly seen typically in the inferior interpalpebral zone. And filamentary keratitis is the another corneal manifestation which we usually see. Then some other beings like epithelial defect and SPKs. So the severe diffuse epithelial damage leads to SPK, and there is also, in such condition, there is always a risk of secondary infection. Then another, some of the corneal manifestation are neovascularization and sterile ulceration, and also decreased sensitivity and scarring, which are seen. Scarring which are seen, usually these patients does not have are not very symptomatic, and these are some of the systemic medication which we use as an immunosuppressive agent, which helps in decreasing the symptoms of dry eye, severe dry eye. So some of the common ones are prednisolone, most of the people uses, and the other ones are like cyclosporin and tacrolimus. So in rheumatoid arthritis, mostly we uses, patients are given by rheumatologists to be started with methotrexate and mycophenolate. So, and cyclophosphamide are some of the other systemic immunosuppressant. And one of the newer agents which we have started using is lifitegrast. So that actually blocks the LFA antagonist to ICAM1, and it prevents the migration of APC to nearby lymph nodes, and which in turn prevents the activation of T cell. Thus, it reduces the inflammatory reaction and reduces symptoms of dry eye. These are some of the other modalities which we can use to relieve the symptoms, like scleral lenses can be used, and they have various advantage over other modalities, like it facilitates healing process and prevent further desiccation of ocular surface, and it provides constantly hydrates the cornea with the fluid reservoir. So this was one of the case we have seen who came to us with the symptoms of severe dry eye with the BCVA of 2030 and 2050. Later on, we saw the Schirmer, and it was 0 in both the eyes. And then this patient was asked to get the blood workup done, and we found that RA factor was 785, and her others serology was 292 for anti-CCP. So this patient was referred to rheumatologist and was started with methotrexate doses and along with the folic acid. And later on, we also started with a patient with lubricating eye drops and prednisolone to reduce the symptom. Later on, after 1 year, this patient came to us with the epithelial breakdown in both the eyes. So this was typical looking like a geographic ulcer. So we started the patient with oral acyclovir along with topical acyclovir ointment. Then this patient was followed, and later on, this patient epithelial breakdown was resolved. Then this patient developed severe SPKs and was started with CMC and along with other lubricating eye drops along with prednisolone acetate, and her methotrexate was continued overall during this period to reduce the rheumatoid arthritis symptoms. Thank you.
Thank you. I think that was an excellent presentation, and it highlighted that it's not just the topical lubricants which are important, but treating the immunocompromised, changing the immunomodulation is also goes a long way in treating some of these severe manifestations. Thank you so much for that.
I request Dr. Sel sir to give the certificate to Dr. Harsita. Next speaker, Dr. Jagdish Rana sir. Topic on IRPL treatment for dry eye disease.
So good evening, friends. So this is today's last lecture. So this lecture is between you and Haiti, and then our inauguration function. Friends, this is a new topic. It's a new treatment. IRPL treatment, intense regulatory pulse light treatment for the dry. It has both very importance, financial way as well as the academic and the treatment for the patient. So its mechanism of action is to stimulate the parasympathetic nerve connected to the meibomian gland, which in turn stimulate the secretion, contraction, and also to some extent regeneration of the glands. So indication includes evaporated type of dry eye, that is MGD, most common of type of dry eye, that is in 86% of the cases, and resistant cases of a dry eye where we are not able to get adequate result in spite of the treatment available given to the patient. So there are the contraindication: pregnancy, recent sunburn or excessive sun exposure, very dark skin type 6, photosensitizing drugs, and skin condition and active skin infection. So IPL treatment is already available. So what is the difference between IPL and IRPL? So IRPL is a more precise and targeted in its approach to meibomian gland and specifically designed for the dry eye, whereas IPL is designed for the skin disease developed, and it is used for the dry eye cases also. The key difference is regulated nature of light pulses in IRPL compared to less regulated pulses in IPL, which may decrease in intensity towards the end. Neurological stimulation is seen in IRPL, which is not seen with IPL, and efficacy and longevity is also more with IRPL in compared to IPL. And IPL benefits may diminish over the time, leading to more frequent sessions with IPL. Safety, we consider it's safe for the patient from skin type 1 to 6, not indicated for the darker skin, and we have to reduce the treatment or energy depending on the skin darkness. The side effect of the IRP are not much. It is usually mild discomfort, stinging and burning during the treatment, warm sensation. Sometimes mild skin sunburn-like effect may appear on the faces. So management of side effect is very simple: cool compresses, sunglasses, and we have to avoid the prolonged exposure to sunlight immediately after the treatment. So number of the places given are 4 in the lower area and 1 over the temporal area. So this is given 4 where it is given lower lid for the lower lid meibomian gland and temporally 1 for the upper lid meibomian gland. This stimulation causes the meibomian gland to return back to normal activity, decreasing the patient problem. These places areas are the areas where parasympathetic nerve passes. So these places leads to nerve stimulation, which in turn leads to meibomian gland stimulation, which in turn leads to lipid layer secretion, and lacrimal flow is stabilized and leading to relief in the symptoms of a pain. So treatment protocol includes 4 settings of the places: 0, 15, and 45. And in case of severe cases, we have to give 4th and 75th day also. Efficacy, with 85% efficacy, there is a significant margin of improvement in patient symptoms. And most of the patients get improved with the 3rd or 4th sitting in all symptoms. So duration of effect varies from 6 months to 3 years. Patient getting initial relief, short-term improvement after 2nd or 3rd sitting, and long-term effect is a cumulative effect of all sittings. And we may have to give the maintenance sitting every yearly if the patient needs. And there can be variable result depending on the severity of a dry eye and individual variable response to the treatment. So this is the important. It's often a part of comprehensive diet management plan. It is not the only treatment which will give improvement to the dry eye patient. So it includes other therapy also, including dry eye, medication, and other procedures. See this small video of IL treatment given to my patient. This is an EI machine from the ESW company from France. Here is a prepaid card, just like a mobile phone, loaded with a particular treatment doses. We can have a programming as per the darkness of the skin. We can increase the energy or decrease the energy as per the color of the skin. So program depends on the color of the skin also. Now the machine is ready to give the IRPL treatment. So protective glasses are applied over the patient's eye. A gel is applied over the treatment area. Protective glasses are also worn by the doctor, and for setting over and lower lid. It is given in the OPD. Treatment is also done as an outpatient department. Patient is happy after the treatment. And the treatment is over just in 1 or 2 minutes. So follow-up is also essential. We have to take more time, chair time to educate the patient that disease, dye is a chronic and progressive disease, and each patient may not improve with a single treatment or a single treatment plan. It may need a variable treatment along with the IRPL also. So these are the symptoms. You have all the symptoms. You are a patient of dry eye, and you should consult your dye specialist. Thank you. Thank you very much.
Sir, what is the cost of the machine?
Cost of the machine. It's variable as per the doctor.
Thank you, sir. That was a wonderful talk. How frequently this has to be repeated for the patient? How frequently you have to repeat the procedure? For example, the system that we have at RP center, once you do it, we need to repeat it after 1 year. So what about this machine?
So we are giving a 4 sitting to the patient, 0, 15, 45, and 75. Then we have to assess the patient, depending the patient requirement or relief of the dye, we have to repeat the session. See, patient is getting relief, we may not repeat the 1 year maintenance.
So the company itself doesn't propose that this has to be repeated. You have to plan it.
More of the literature is not available in Google. This is what I have found. Company is also not providing all this. So this is something new, and we have to learn on the patient only. Company is also not providing this much. This is what I have got from the Google only. So we have to apply on the patient and we have to learn.
Thank you, sir. I request Dr. Jagdish Rana sir to give the certificate. And please, all the speaker come on the stage for the group photograph for this session. I request all the speaker of this session to come on the stage for the group photograph. Dr. Sonal Ma'am, Dr. Harshita.
Now there will be a break for high tea from 5 to 5:30. After that, we will have a grand inauguration function of this midterm AGOC. And everybody is requested to attend that function. And in between that function, there will be a lucky draw for mobile phone. So let's meet after a tea break.
Excuse me, everyone. I'd like to request all the delegates to take their seats. We are just about to start our inaugural ceremony. Our chief guest has already arrived. I kindly request everyone to take your seat, please. We are just about to start our inaugural ceremony. All the trade partners standing behind, please take your seat.
Excuse me. Hello. I request everyone to take a seat. All the delegates, please take your seat. We are going to start our inauguration function. So everyone is requested to take their seats. Thank you so much.
Good evening, everyone. Once again, I would like to take this opportunity to welcome all the delegates, faculties, national faculties, on behalf of organizing committee, 4th midterm conference of All Gujarat Ophthalmological Society. I, Dr. Bhavik Zala, treasurer of AGOC, warm welcome everyone for the inaugural ceremony. I would like to invite on stage our today's chief guest, Pujya Shri Umanand Saraswati ji, along with Dr. Jagdish Rana sir, our executive secretary, president sir, Dr. Vishnu Patel, to bring the chief guest on stage, followed by lamp lighting. I would like to invite Dr. Sandip Arora, sir, scientific committee chairman, Dr. Bhavik Zala, treasurer, All Gujarat Ophthalmological Society, Dr. Ashish Saxena, sir, conference secretary, Dr. Mukesh Patel, Dr. Narendra Singh Verma, chairman, 4th midterm, Dr. Amit Shah, sir, and Dr. Divyang Brahmbhatt, sir, to join the stage. Dr. Mukesh Patel and Dr. Narendra Singh Verma, sir, please join the stage. Now I would like to request our own beloved AGS Secretary Dr. Jagdish Rana sir to invite all the dignitaries on the dais and our chief guest to proceed for the lamp lighting and prayer to inaugurate the function.
शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु।
Thank you, everyone. We have witnessed a very tragic and heartbreaking incident happen just few days back on the 12th of June, in which many lives have lost, including some medical students and their family. I would like to request all of you to stand at your place and observe 2 minutes silence to pray for them. Om Shanti, Shanti, Shanti. Now, I would like to invite our conference secretary, Dr. Ashish Saxena sir, to brief about the fourth midterm conference of All Gujarat Ophthalmic Society.
Good evening, everybody. As per our tradition, we are organizing this fourth midterm conference AGOC at Bhagwati Resort, Abu Road, with a very what we can say nominal registration fees. We are providing the complimentary stay, transportation, silver coin. Even this time we are providing bed sheets also as a complimentary gift, along with the lucky draw, particularly EV scooter, along with many other gifts also, in which I think every alternate delegate will get some gift also, lucky draw. And because of these, what we can say, arrangement, we have started 2 months back, and we have visited this site, many sites on the same day, but we finally select this site, and we feel that it is very proper for our midterm AGOC. Along with this introduction of our fourth midterm AGOC, I want to introduce our chief guest. I think his introduction will be properly we can explain in Hindi language. आज हमारे जो कार्यक्रम के मुख्य अध्यक्ष हैं वो हैं पूज्य श्री स्वामी उमानंद सरस्वती जी, जो कि आर्य गुरुकुल महाविद्यालय आबू पर्वत के अध्यक्ष भी हैं और आचार्य भी हैं। वे आर्य समाज मंदिर आबू पर्वत के प्रधान भी हैं। इसके अलावा महर्षि दयानंद जी की जो उत्तराधिकारी परोपकारी सभा है अजमेर की, उसके वो न्यासी हैं। महर्षि दयानंद स्मृति भवन न्यास जोधपुर के भी वो न्यासी हैं, और आर्य वीर दल राजस्थान के वो संरक्षक हैं। तो इतने पूजनीय गुरु जो हैं हमारे आज अतिथि बने हैं, ये हम सब के लिए बहुत ही सौभाग्य की बात है, और हम उनसे आशीर्वाद भी लेंगे। हम along with this our scientific session, we can get spiritual knowledge also from him. So I would like to invite our AGOC secretary, Dr. Jagdish Rana sir, to felicitate him. Memento of Ram Mandir. I would like to invite our AGO's secretary, Dr. Jagdish Rana, sir, to give secretarial speech. Sir, please.
Good evening, friends. I welcome you all on behalf of All Gujarat Ophthalmological Society. As you all know, this is the consecutive fourth midterm AGOSC, which we are organizing as a destination conference outside of Gujarat. And so, you know, it requires dedication and tremendous exercise to organize such a conference outside of Gujarat with our regular practice and our family burden also. So I am blessed with my team, Dr. Bhavik Zala, Dr. Bhumik Rawal, Dr. Ashish Saxena, Dr. Parth, and all other my friends. They are all my dedicated friends who are working on behalf of me to making this conference a very much successful and a memorable one. So I am very much thankful to my team, and also I am thankful to all my delegates. Without your presence and active participation, this conference would not have been successful and memorable one. So thank you very much. And also I am thankful to my state delegates who have participated this time, maximum out of these one conferences. And with their support only, I am able to provide everything complimentary and very much comfortable conference to all of our delegates. Thank you so much.
Thank you very much, sir. As I told you that as our tradition in every conferences, we felicitate our renowned senior ophthalmologists from all over the Gujarat. This time we have selected 4 senior renowned ophthalmologists, but Dr. Amit Mehta sir, Dr. Girish Jethwa sir, and Dr. Amrutbhai Patel sir, because of their social commitment, they couldn't attend our inauguration function. So we will manage to felicitate them at their own place.
Good evening, everyone. I would like to invite Dr. Sunil Saha sir. He's a senior most ophthalmologist from North Gujarat. He is doing his private practice since last 36 years from 1988. He has done his UG and PG both from BJMC, Ahmedabad. He has obtained his fellowship as a vitreoretinal surgeon from the Retina Foundation, Dr. Nagpal's Eye Hospital from 1998. He has worked at the Sarvodaya Arogya Nidhi Hospital, Radhanpur, and gave services in many surgical free camps also. He is in private practice since last 1988. He has served as the president of All Gujarat Ophthalmological Society in the year 2007 and 8. He has been also a president of North Gujarat Ophthalmological Society since many years. He has appointed as a member managing committee All India Ophthalmological Society for 6 years from 2009 to 2011 and 2011 to 2014. He is author of a published one book, that is the Ratan Jevi Aankh Nu Karo Jatan in Gujarati. So in Marathi and Hindi language also. So I would request Dr. Sunil Saha sir to come on the stage, and I would request Pujya Swamiji sir to felicitate our senior ophthalmologist, Dr. Sunil Saha sir. Thank you. I will request Dr. Sunil Shah sir to share his vast experience. The stage is over to you, sir.
Dignitaries on the dais and dear colleagues, I am grateful to the All Gujarat Ophthalmological Society Committee for the honor bestowed upon me today. I am active in various organizations like IMA, Rotary, Jain Doctors Federation, Jain Jagruti Center, and so on. But ophthalmological societies are closest to me, closest to my heart. I have served as a president All Gujarat Ophthalmological Society in 2007-8 and managing committee AIOS from 2009 to 2014. I have served as a president North Gujarat Ophthalmological Society for many years. I appreciate the academic activities of our society, and I also admire the feeling of brotherhood amongst our members. I have always got cooperation from our members. For all my endeavors, last Sunday was Father's Day, and I remember my father, late Dr. M.J. Shah, who also served as the president of this society, and he was also managing committee member in All India Ophthalmological Society. Finally, I thank you all and my best wishes to the society for the further progress. Thank you very much.
Unfortunately, Dr. Amit Mehsa sir has not able to attend the inauguration ceremony. His mother has just discharged from ICU. She is 93 years old, so he has to be with her. Dr. Girish Jethwa's one of the close friend, has died, has lost his life in the last plane crash, and his body was just recovered and handed over to the family just yesterday evening. So the funeral ceremony was today, so he is also not able to attend the inauguration program. And Dr. Amrut Patel sir has some social reasons because of him, because of it, he is not able to attend the conference. I would invite Dr. Saxena sir and Dr. Bhavik to proceed for the inauguration function. Thank you.
Now we would like to felicitate our national faculties. First of all, I would like to invite Dr. T.P. Lahane sir on stage. Dr. T.P. Lahane sir is like well-known personality. We don't have to tell much things about him, but in short intro, I'll tell few things. He's the founder chairman of Raghunath Netralaya in Dadar and Manorama Netralaya in Mulund. He's a former director medical education research in Maharashtra. He's former dean of Grant Medical College and Sir J.J. Hospital in Mumbai. And he has treated over 50 lakh patients. He has personally operated 177,000 cataracts and 32,000 other surgeries. He was awarded Padma Shri in 2008, and he has more than 400 awards to his credit. He delivered more than 500 lectures in different conferences, and he has demonstrated live surgeries in 211 different conferences. So this is around 10 to 15 ophthalmologists' work he has alone done till now, and he's keep on doing it. So thank you so much, sir, for blessing us with your knowledge. Thank you, sir.
Thank you, sir. Now, I would like to invite our next national faculty, Dr. Ragini Parekh ma'am. She has performed more than 80,000 cataract surgery and have examined more than 10 lakhs of patients, received 100 Women Achievers Award at the hands of Honorable Sri Pranab Mukherjee, Honorable President of India in 2016. She had worked in more than 500 camps in rural and tribal areas of Maharashtra, have received more than 50 awards for community ophthalmology, have taught more than 1,000 undergraduate and more than 100 postgraduate students. Thank you so much, ma'am.
Now, I would like to invite Dr. Arvind Kumar Maurya, sir, our dashing ophthalmologist. Who doesn't know him? He is basically from Rajasthan, and he's practicing currently here in Hyderabad. He's the national convener of AIOS Adverse Event Committee, AIOS FICO Board Executive Member, Chief Editor in Video Section, AIOS Dynamic eBook for cataract, glaucoma, refractive squint, and pediatric ophthalmology and medical retina services he's handling in Hyderabad. He's first Indian to win Ophthalmic Star Award at Amsterdam, ESCRS in 2021. And he has plenty of awards in his name. If I'll keep on telling that, it will be taking around 4 to 5 hours. Thank you so much, Maurya sir, for coming here. And today we are inaugurating his book also in the end.
Now next, our next guest faculty is Dr. Prafulla Kumar Maharana. He has done his MD residency from AIMS New Delhi and right now Secretary of Delhi Ophthalmic Society. Published 395 Google Scholar 136 PubMed index papers. He has done Best Surgical Technique Awards from Renzo, Australia, Young Achiever Award, ISC KRS. He is editor of 3 Amazon bestseller books on the ophthalmology, Ophthalmology Clinic Part 2, Postgraduate Ophthalmology, and Ophthalmology Clinics Part 1. Thank you so much, sir. Okay, so the whole function cannot be completed without the team effort. So for the first time in our midterm conference, we have a bunch of committee members who have done their job in their respective area and make sure this whole function and whole conference go very smoothly. So I would like to invite our all organizing committee members one by one for appreciation awards handed over by our chief guest, sir, Dr. Jagdish Rana, sir. First of all, I would like to invite the chairman of our conference, Dr. Mukesh Patel, sir, and Dr. Narendra Singh Verma. Thank you so much, sir, for your great efforts and all the support. Dr. Mukesh Patel sir has specially arranged breakfast for all the delegates who are coming through the bus transport. Second time, last year also he has done the same thing for our all delegates. Yes, sir.
Now I would like to invite co-chairman of conference, Dr. Bhavesh Patel and Dr. Prakash Rathod.
If they are here, please join the stage.
Joint secretaries, please be ready. એટલે સેક્રેટરી તો ઉપર જ છે ને
પહેલા તમારું Next, our conference secretary, Dr. Ashish Saxena sir. He has done a great effort and tried very hard to make it possible.
Now I would like to invite our joint secretaries of the conference, Dr. Mohak Shah, Dr. Shail Vasavda, Dr. Gaurav Mehta, Dr. Sanjay Patel, Dr. Mihir Patel, and Dr. Aditya Desai.
Dr. Shail Vasavda, Dr. Gaurav Mehta, Dr. Mihir Patel. Next, Conference Scientific Committee. So these people make sure that whole program goes very smooth and all the aspect of ophthalmology covered. Dr. Kushal Deliwala, Dr. Parth Rana, Dr. Keshvi Shah, and Dr. Ashish Gachar. They have done really hard work. So please make a great round of applause for all of them.
Now I would like to invite conference treasurers, Dr. Bhaumik Rawal and Dr. Rupesh Shah, sir. Dr. Rupesh Shah.
Next, co-treasurer of our conference, Dr. Siddharth Gosai and Dr. Himanshu Jodhani.
Next, I would like to invite Conference Advisory Committee, Dr. Hitesh Ramanuj, Dr. Ashish Bojak, Dr. Dikesh Goel, Dr. Nutan Shah, and Dr. Kamlesh Kalaria.
Next, our entertainment committee, Dr. Akash Patel, Dr. Jitendra Vidhani, Dr. Jignesh Gosai, sir.
Next is our most important audiovisual committee, Dr. Alpesh Rajput, Dr. Dhaval Rajpara, Dr. Ankit Shah from Ahmedabad, Dr. Alap Bhavishi, and Dr. Mehul Patel.
Next is our accommodation committee, Dr. Bhavik Zala, Dr. Bhaumik Rawal, Dr. Dhaval Shah, Dr. Jai Prakash Purohit, and Dr. Kanisha Kotaria. Transport.
Yes. Next committee is Transportation Committee, Dr. Meet Ramani, Dr. Sapan Shah, Dr. Jatin Mewada, Dr. Mitesh Kokhani, and Dr. Bhargav Kotadia.
If they are present, they can come on the stage. Next, our Food Management Committee, Dr. Sanjay Govil, Dr. Bhavesh Patel, Dr. Ankit Shah from Himatnagar, and Dr. Jignesh Jetwa. Arvind Agrawal. Arvind Agrawal. Arvind Agrawal.
પેટ્રોલનો છે પેટ્રોલ આવ્યા છે એટલે બનાવેલા છે ખરા હા 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 જે આવ્યો એને બોલાવી લો Now we would like to invite our dear patrons, due to whom we are able to do all this work. Dr. Amit Shah, Dr. Abhay Vasavda, Dr. Bakulesh Khamar, Dr. Amrut Patel, Dr. Parimal Desai, Dr. Dilip Agrawal, Dr. Madhav Jodani, Dr. Divyang Brahmbhatt, and Dr. Darshan Bhavishi. હા હું બોલું છું આના પછી છે ને આ બધા છે ને હા હા તમારું હા હિમાંશુ પ્લીઝ ના જોડાણી છે અરવિંદ અગ્રવાલ ને બોલાય હા ડોક્ટર શૈલ વસાવડા પ્લીઝ ખમાર સર બકુલેશ ખમાર સર પાછળ મેમ યુ કેન ક્યાં છે સર સર Now we would like to present the memento to AGOS Secretary, Dr. Jagdish Rana, sir. Now I would like to invite our chief guest, sir, to tell 2 words of wisdom to all of us. Sir.
ओम यो भूतं च भव्यं च सर्वं यश्चाधितिष्ठति स्वर्यस्य च केवलं तस्मै ज्येष्ठाय ब्रह्मणे नमः। तस्मै ज्येष्ठाय ब्रह्मणे नमः। अखिल गुजरात नेत्र चिकित्सा समिति के समस्त पदाधिकारी, महामंत्री डॉक्टर जगदीश राणा जी, अन्य सभी चिकित्सक बंधु, संपूर्ण गुजरात से और गुजरात के बाहर से भी कुछ डॉक्टर पधारे हैं। इस समिति का, सोसाइटी का जो ध्येय वाक्य है वो हमें बहुत कुछ मार्गदर्शित करता है। तमसो मा ज्योतिर्गमय, अंधकार से प्रकाश की ओर हम निरंतर बढ़ते रहें। परमपिता परमात्मा ने इस दुनिया की रचना की, सृष्टि की रचना की, और उसमें प्रकाश का जो मुख्य स्रोत है वो सूर्य है। और हमारे शरीर को, हमारे शरीर की जो रचना है वो भी परमात्मा ने ही की। माता पिता यह नहीं जानते हैं कि आँख, हृदय, लीवर, फेफड़े कैसे बने। तो परमात्मा ने जहाँ सृष्टि की रचना की, वहाँ हम सबकी माता के गर्भ में हम सबके शरीरों की भी रचना की। तो उस जगत पिता के पश्चात कर्म दोष के कारण अथवा कुछ शारीरिक विकलताओं के कारण जब व्यक्ति दृष्टि रहित होता है, देखने में उसको असक्षम पाया जाता है। बहुत से बालक जन्म के साथ ही बहुत से रोगों के कारण ग्रसित हो जाते हैं। तो परमात्मा और माँ के बाद दूसरा यदि कोई स्थान है तो वो सब आपका है, डॉक्टरों का है, चिकित्सकों का है। आप सब केवल व्यवसाय, आर्थिक दृष्टिकोण से ये कार्य नहीं कर रहे हैं। ये अपने यहाँ पर एक कहावत है, चलो सखी वहां चले जहां मिले यदुनाथ, दूध बेचन हरी मिले एक पंथ दो काज। ये गोपी लोग कहते थे कि चलो हम वहां चलते हैं कि दूध भी बेच के आएंगे और श्री कृष्ण को भी मिल के आएंगे। तो आप सबका जो कार्य है वो व्यवसाय की दृष्टि से, अर्थोपार्जन की दृष्टि से जहां महत्वपूर्ण है, उसके साथ साथ सेवा की दृष्टि से मानव को परमात्मा ने तो जो आयु, जाति, भोग दिया था वो दिया। उसके बाद उसके जीवन को श्रेष्ठ से श्रेष्ठतम बनाने के लिए, अच्छे से अच्छा बनाने के लिए
आप सबका महत्वपूर्ण योगदान होता है, उसके लिए आप सब निस्संदेह निश्चित रूप से अभिनंदन और धन्यवाद के पात्र हैं। अपने वेदों में जहाँ जीव जगत के कल्याण की प्रार्थना की है, हम जब प्रातःकाल सायंकाल संध्योपासना करते हैं, वहाँ परमात्मा से प्रार्थना करते हैं। हाथ में जल लेकर के बोलते ओम चक्षुः चक्षुः, अर्थात हे प्रभु आप मेरी आंखों में ज्योति भर देना। भुवः पुनातु नेत्रयो, हे परमात्मा आप मेरे नेत्रों को पवित्र कर दीजिए। अक्षणोर में चक्षुरस्तु, मेरी दोनों आंखों में ज्योति सदा रहे। जहां हम जीवेम शरदः शतम की प्रार्थना करते हैं कि हम 100 वर्ष तक जीवित रहे, वहां यह भी प्रार्थना करते हैं पश्येम शरदः शतम, हम 100 वर्ष तक अच्छा देखें। आंखें परमात्मा ने दी है, आंख एक इंद्रिय है, उसका हम सदुपयोग भी कर सकते हैं और दुरुपयोग भी कर सकते हैं। इसलिए वेद में कहा भद्रम पश्येम अक्षिभिः शृणुयामदे, जहां हम कानों से अच्छा सुने वहां आंखों से भद्र देखें, कल्याणकारी देखें। शास्त्र कहता है मनुष्य तो हम सब है, लेकिन सही देखने की दृष्टि किसकी है? मातृवत परदारेषु लोष्टवत पर द्रव्येषु आत्मवत सर्वभूतेषु पश्यति स पश्यति। अन्यों की बहन बेटी को अपनी माता के समान जो दृष्टि से, पवित्र दृष्टि से देखता है, दूसरे के धन को पत्थर के समान समझता है। और आत्मवत सर्वभूतेषु, जैसे मेरी आत्मा है वैसे ही सब प्राणियों में, सब जीवों में आत्मा है। तो जो करने से, जो बोलने से पीड़ा होती है, वैसा व्यवहार मैं किसी के साथ न करूं, आत्मवत व्यवहार करूं। ऐसा जो देखता है वो वस्तुतः सही देखता है। हम जहां विश्व कल्याण की प्रार्थना करते हैं, हम सबका सौभाग्य है कि हमारा जन्म भारतवर्ष में हुआ है, सनातन वैदिक धर्म में हुआ है। भवन्तु सुखिनः, वहां भी वाक्य आता है सर्वे भद्राणि पश्यन्तु, सब भद्र देखें। भद्र कहते हैं कल्याण को। हमारी दृष्टि में सदा कल्याणकारी ही होना चाहिए, क्योंकि व्यक्ति मन से सोचता है, फिर इंद्रियों से कर्म करता है। तो आंखों का महत्व अनेकों स्थानों पर मैंने आपको उद्धृत किया कि स्थान स्थान पर जहां वेद में हम अन्य प्रार्थनाएं करते, वहां आंखों के लिए भी प्रार्थना करते हैं। और हिंदी में कहावत भी है, सब आत्मा के बाद आंख को ठीक करने वाले दैवीय पुरुष के रूप में जहां उपस्थित है। आप सबका कार्य बहुत ही अभिनंदनीय और वंदनीय है। जहां हम आर्थिक दृष्टिकोण से, क्योंकि आप गृहस्थ में हैं, हर व्यक्ति की अपनी भौतिक सुविधाएं और उसके लिए धन उपार्जन आवश्यक है, उसके साथ साथ आप निश्चित रूप से सेवा के कार्य भी करते हैं। और नहीं करते हैं तो हमें आज ये संकल्प करके यहाँ से जाना है कि कोई गरीब है, असहाय है, अनाथ है, तो उसका हम न्यूनतम कम से कम चिकित्सा, हम कोई, भगवान ने हमसे कोई रुपया भी लिया नहीं है। इतनी सुंदर आंखें बना के दी है, परमात्मा ने एक भी रुपया नहीं लिया है। इतना सुंदर शरीर और शरीर के सब अंग और सृष्टि के प्रत्येक पदार्थ को जीव मात्र के कल्याण के लिए दिया है। वो परमात्मा कभी हमसे कोई शुल्क नहीं लेता है। तो हमारा कर्तव्य बनता है कि हम भी उस परमात्मा की कृपा के कारण ये श्रेष्ठ कर्म, नहीं तो संसार में 800 करोड़ लोग हैं और उसमें बहुत सारे दुखी लोग हैं, बहुत सारे पीड़ित, शोषित और वंचित हैं। जहां आप यहाँ आबू रोड में है, ये पूरा तहसील जो है वो आदिवासी बहुल है। 80% लोग आदिवासी, उनका जीवन आप इस पहाड़ के पीछे जाके देखिए, हम जाते हैं वर्ष में 2-3 बार, तो हमें पता चलता है कि बहुत जीवन कष्टमय है, सबका जीवन सुखमय नहीं है। तो परमात्मा की हम सब पर कृपा है। आप सब अच्छे परिवार में उत्पन्न हुए, माता पिता ने पुरुषार्थ करके आप सबको खूब पढ़ाया लिखाया, आपने अपने पुरुषार्थ से एक समाज में अच्छा स्थान प्राप्त किया। तो ये सब होने के बाद हमारा कर्तव्य बनता है कि जिस समाज से परमात्मा की कृपा से हमें इतना प्राप्त हुआ, क्योंकि भगवान की सेवा भोग आप लगाते हैं वो स्वीकार हो ना हो, लेकिन उसके बनाए हुए जो प्राणी हैं उनकी आप जो सेवा करते हैं, दीन दुखी अनाथ और निर्धन की, वो सच्ची सेवा है, वो ईश्वरीय सेवा है। तो आज आप संकल्प करेंगे कि जीवन में हम दीन दुखियों का भी सहयोग करेंगे। परमपिता परमात्मा आप सबको ऐसा सद्बुद्धि और सामर्थ्य दे, आपके हाथों में ऐसा यश हो कि आप जिसका भी ऑपरेशन करें वो सदा उन आपके ऑपरेशन सफल हो, रोगी का भी कल्याण हो। और ईश्वर ने जो हमें ये जीवन दिया है वो केवल भोग करने के लिए नहीं दिया है, क्योंकि भोग जो है वो तो पशु पक्षी भी करते हैं, वो भी भोजन करते हैं, वो भी संतान उत्पन्न करते हैं, वो भी शारीरिक सुखों को प्राप्त करते हैं। मनुष्य और पशुओं में जो अंतर है वो है धर्म का। और धर्म कोई क्रिया पद्धति पूजा पद्धति नहीं है, श्रेष्ठ जीवन मूल्यों को धारण करने का नाम धर्म है। तो सेवा करना भी बहुत बड़ा धर्म है। संस्कृत साहित्य में कहा है, सेवा धर्म परम गहनो योगिनाम अप्यगम्य, कि सेवा करना योगी लोगों के लिए भी कठिन है। तो आप सब श्रेष्ठ सेवक बने, और जहां धन उपार्जन कर रहे हैं उसके साथ साथ सेवा का भी जो धन है, क्योंकि ये जो शरीर भौतिक जो धन है वो तो अपने 100 वर्ष तक ही काम आने वाला है, साथ में आने वाला नहीं। लेकिन धर्म रूपी धन जो आप इकट्ठा करेंगे, किसी का आशीर्वाद लेंगे, किसी की सेवा नहीं है वो सेवा के द्वारा भारत और भारतीयों की सेवा करें, उसके बाद आप विदेशों में भी सेवा करें, क्योंकि हम भेद नहीं करते कि ये हमारे धर्म का है, हमारे मत और पंथ संप्रदाय सुखी ना। तो मैं अधिक ना कहता हुआ यही कहूंगा कि आप सबको परमपिता परमात्मा खूब शक्ति सामर्थ्य सद्बुद्धि दे। आप जहाँ धर्म रूपी धन कमाए वहाँ सेवा रूपी धन और भौतिक धन को भी उपार्जन करें। आप सबको मिलने का और सम्मानित करने का सौभाग्य डॉक्टर जगदीश राणा जी ने प्रदान किया, इसके लिए उनका और आप सबका भी मैं धन्यवाद ज्ञापित करता हूँ। ओम शांति ही शांति।
धन्यवाद पूजनीय स्वामी जी। अब जब आज हमारे बीच में आचार्य जी उपस्थित हैं तो फिर आज हम उनका एक पुस्तक विमोचन के लिए लाभ भी लेना चाहते हैं। आई वुड इनवाइट डॉक्टर अरविंद मौर्य सर for the book release and Dr. T.P. Lane sir for the book release. It is the book written on cornea and the author are Dr. T.P. Lane sir, Dr. Arvind Maurya sir and Dr. Titiyal sir. तो गुरुजी से मैं निवेदन करूंगा कि एक पुस्तक विमोचन के लिए अपना आशीर्वाद दें।
Now I would like to invite Dr. Santosh Honavar on stage. We all know him as a best oculoplasty surgeon in India. He is the General Secretary of All India Ophthalmological Society. He is a Director of Medical Services and Center of Sight. He is Director of Department of Oncology and Oculoplasty at Center of Sight, Hyderabad. And he is the National Director in National Retinoblastoma Foundation. There are plenty of awards in his name, but we all love him for his dedicated work in ocular oncology, specific the 3D surgeries in ocular oncology. Thank you so much, sir, for coming here.
Now I will request Mr. Arvind Agrawal, the owner and the managing director of this venue, where we all are enjoying this conference and we will enjoy the dinner and everything. He is a very kind of businessman, we can say, and he is running Bharat Vikas Parishad in this area also. So along with this business, he is doing too much social welfare also, and he is so helpful in our arrangement of this venue. So we would like to give him honor.
Now we would like to invite Dr. Sandip Arora, sir, our scientific committee chairman, for the felicitation. Please. Arora, sir.
Now, we would be very thankful to our chief guest, Pujaniya Shri Om Anand Saraswati ji, for his spiritual lecture and sparing valuable time for our inauguration function. And he has inspired us for welfare programs and services of human being. So I'm very thankful to him.
We are very thankful to our Honorary Secretary, Dr. Jagdish Rana, sir, for guiding us through this journey of the fourth midterm AGOS conference. Thank you, sir.
I'm also thankful to Dr. Vishnu Patel, President of our AGOS, who could not attend the conference, but he has supported for managing this whole thing.
I would like to thank all the organizing committee members from all of us. Without them, this could not be happen. Thank you so much.
I'm also thankful to our national and international faculties who made our scientific sessions very fruitful and very interesting. National faculties, you know very well that Dr. T.P. Lane sir, Dr. Arvind Maurya sir, Dr. Agni madam, Dr. Marana sir, Dr. Santosh Sonawar sir, and international faculties Dr. Barbara, Dr. Vignesh Raja, Dr. Barbara from Italy, and Dr. Vignesh Raja from Australia, and Dr. Sanyam from Nepal.
We would like to thank our renowned ophthalmologists, Dr. Amrutbhai Patel, Dr. Girishbhai Jetwa, Dr. Sunil Shah, Dr. Amitbhai Mehta, for accepting our invitation, for felicitating them.
I would like to thank all delegates and AGOS members who made this midterm conference grand success.
We would like to thank all trade partners, Biotech, Ocularis Mankind, Protec Remedies, Appasamy Associate, Cipla, MyHealthCap.
We are thankful to Alcon, Sun Pharma, Johnson Johnson, Neomedics, Intas, and Alchem.
We are thankful to Yana Ophthalmics, Hazel Pharma, Dream Pharma, Orite Pharmaceuticals, Hoya Surgical Optics, and Zestacare.
We are also thankful to LabViews, Zivira, Care Group, Sky Vision, Bayer, and Insight Pharma.
We are thankful to Newgen, Ocean Ophthalmics, NRI Vision Care, BKC Pharmaceutical, Microlabs, and Cyprec Life Science.
We are also thankful to Roche, His Highness, Ajanta Pharma, Entod, Lupin, and Bosch and Lomb. We are also very much thankful to Bhagwati Hotel management staff and Arvind Bhai especially, who arranged everything very easily to arrange all these conference programs.
We are thanking Mr. Jitendra Bhai Chaudhary from the Connex Craft and his audiovisual team to make this event successful.
We are extremely thankful Dr. Mukesh Patel from Mehsana, who arranged a nice breakfast for our bus traveling doctors. This is second time, and everybody appreciated also. So we are thankful to all.
Last but not the least, I would like to thank Microvision Pharma for arranging a bus and a smooth conduct of the all residents and the delegates from Ahmedabad to here. Thank you all.
Now we will proceed for today's lucky draw. So be ready for today's lucky draw. For delegates and trade partners.
First of all, we are doing a lucky draw of power bank, Zebronics power bank MB 10,000 S15 for trade partners. Microlab. The second part, we are doing a lucky draw for the Podtronics car power 3.0 for trade on. Now we'll go for the lucky draw of delegates.
Intas.
Okay, Intas.
Sure. Okay.
Now we are doing lucky draw for Zebronics Power Bank MB 10,000 S15 for delegates.
डॉक्टर परेश परेश वसरत, डॉक्टर परेश वसरत जी।
The next gift is 65-watt fast charging 4-in-1 sparing data cable for delegates.
डॉक्टर शशांक जी पटेल। शशांक जी एम पटेल।
Whoever is getting these gifts, they are not going to participate in main lucky draw. So either they should be happy or sad.
All the best to others. Okay. Now lucky draw for magnetic charging from the Podtronics delegate.
डॉक्टर अलाप बाविशी।
And the last lucky draw gift for today is Samsung Galaxy M05 mobile, 4GB RAM, 64GB storage, 50 megapixel dual camera, and the bigger 6.7-inch HD display for the delegates.
डॉक्टर शुभांगी जी जैन। शुभांगी जैन नहीं है शायद।
If she is not available, then we'll do another round. All the best to all others.
डॉक्टर महेंद्र जी पटेल।
Dr. Mahendra Patel. Still we have chance, please.
पता चल रहा कौन कौन नहीं है. डॉक्टर अंकित जी शाह, अहमदाबाद.
Dr. Ankit Shah. He is not present. Still we have chance. See the probability of winning the mega event. You have to present here.
डॉक्टर शशांक जी पटेल.
Sorry, sir. Sorry, sir. You are not eligible for the second gift.
चार आउट.
I'm sorry, sir.
Once a gift is given, they are not eligible for anything else. This is by mistake the second chit.
डॉक्टर आभा मोड जी.
मैम को गिफ्ट मिलते मिलते 4 राउंड हो गए, तो आप सबको रिक्वेस्ट है कल प्लीज जब भी मेगा लकी ड्रॉ है यहाँ पे प्रेजेंट रहिएगा. मैक्सिमम चांसेस है मैक्सिमम गिफ्ट्स को विन करने के. थैंक यू.
Before we conclude our inauguration session, we will do this national anthem. So all are requested to stand up your place. राष्ट्रगान करेंगे हम ये कार्यक्रम खत्म होने से पहले, तो सभी से अनुरोध है कि अपनी जगह पे खड़े हो जाएं. सावधान. जनगण मन अधिनायक जय हे,
भारत भाग्य विधाता,
पंजाब सिंध गुजरात
विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा, तब सुख नामे जागे, तब शुभ आशीष मांगे, गाहे तब जय गाथा, जनगण मंगलदायक जय हे, भारत भाग्य विधाता जय हे, जय हे, जय हे, जय 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 हे. भारत माता की